Hmm. Repolarization occurs as a result of what is that? Very good. As a result of what is that wave? That is, sorry, what is that ion? Potassium ion. Now, if at all patient has, if there is a increase of the potassium in the body, more potassium in the body, that means hyperkalemia. During hyperkalemia, what happens to a T wave? Of course, repolarization will occur strongly, leading to tall T waves, okay? Leading to tall T waves. So tall T waves occur as a result of your hyperkalemia. Now you people will end up asking me a question, sir, when you're telling us about hyperkalemia as a result of tall T waves, as a result of which tall T waves are coming, तो ये कौन सी लीड में दिखेगा? See, any of the ion changes, hyperkalemia, hypokalemia, hypernatremia, hyponatremia, इसके अंदर कितने भी ECG changes आता है, these changes will be seen throughout all the leads. सारे लीड में दिखता है. Okay, you need to remember this common point. Okay, now atrial fibrillation में what happens? So guys, what happens here is that ये जो एट्रिया होता है ना, ऐसा दो एट्रिया का चेंबर्स होते हैं, ये दो चेंबर्स होते हैं. When these two chambers get depolarized and contract together, they used to generate our wave called as a P wave. But during the atrial fibrillation, please follow what I'm explaining. These are the two chambers. Okay, these two chambers, they used to contract together and relax, contract together, relax together, contract together, relax together. So एक साथ contract होकर relax होने की वजह से कौन सी वेव आया था अपन को? P wave आया था. Which way we had got? P wave. Now what happens in the atrial fibrillation is that the atria will start to do this action. So regularity of the contraction will be absent. So that means atria will not contract all together. Rather, atria will do this dancing. So if atria was completely contracting and relaxing, it created as a complete P wave. Okay, complete P wave. But in atrial fibrillation, what happens? Complete P wave will be there or not there? No P wave will be there. So you are going to get something like this. Then after that, you will have QRST. Yes, of course, QRST will be there. So when you look here in the atrial fibrillation, do you find a P wave or did not find a P wave? So atrial fibrillation, atria was doing this dance. So if it contracted like this completely, complete P wave. Now it is doing like this means there is no P wave. So this P wave will be absent. This P wave will be absent in a atrial fibrillation. So in a ECG, if you get, for example, no P wave, then the story is over, my dear students. The story is your atrial fibrillation. But no P wave. Is it only criteria? No, there is one more criteria. There is a different RR interval. RR interval will be different. So RR interval will be different means what is that? One R wave to another R wave, the distance will be changing throughout the ECG. This happens as a result of irregular heartbeat happening due to your atrial fibrillation. Sir, how do we remember this? Atrial fibrillation, atria will dance. Point number one. So dancing is there, no P wave, because complete contraction did not occur. So if complete contraction did not occur, no P wave, and regularity is totally absent. So irregular RR interval. So RR interval different with a no P wave. We call it as atrial fibrillation. Okay. Then we have one more disease, that is your atrial flutter. Okay. Now, apart from that, we have one more disease. What is that one more disease? We have ventricular fibrillation. Okay. We have one more disease, that is ventricular flutter. Among which the most important ECG I want you to remember is your atrial fibrillation causes no P wave and a different RR interval. Now we have atrial flutter, we have ventricular fibrillation, ventricular flutter also. Sir, what are these things? Again, please understand, ventricular fibrillation, what happens? Now atria was dancing. In ventricular fibrillation, ventricle will dance. But there is some importance about ventricular fibrillation and flutter, which we will learn after the drugs. Clear? Everybody okay with this much? So far, whatever I taught, understood? And sync mein aa gaye ho? Back to sync, everybody. Come on, guys, tell me something here.
Yes, sir.
Perfect, perfect, perfect. So, chalo padte. Now, yesterday I taught you people one simple concept. That simple concept was a ventricular myocyte was undergoing depolarization. Remember this curve? Remember this curve? Na? So in this curve, what was there? Phase 0 was there, phase 1, phase 2, phase 3, phase 4. Okay. In the phase 0, which ion was coming? Sodium ion was coming. Yes or no? Phase 0, sodium ion was coming. So like this, all the ion changes were occurring. Okay. Now just think about it. Think about it, guys. These, for example, if I block these sodium channels, if I block the sodium channel, for example, I had 5,000 sodium channel. Instead of 5,000, now I will block, my dear students, 4,000 sodium channels I have blocked. Randomly, I'm telling you. I had 5,000, in that 4,000 I have blocked. I have only 1,000. So to reach this point, it will take more time or less time? It will take more time. Why? Because all the sodium channels are not there, only few are there. So it requires more time to reach this voltage. So the graph will change into something like this. Graph would change into something like this. Yes or no? So if you block any ion channel, that means it will lead to something like change of the graph. The change of the graph, whatever is there, we are going to learn it. We are going to learn it. So first thing you need to remember is what are the phases we have. The phases are, we have 5 phases. First one is your phase 0. 5 phases are there in that phase 0. Phase 0 was your sodium ion entry. Sodium ion entry. Okay, so next phase 1. Phase 1 was your potassium ion exit. Okay. Phase 2. Phase 2 was your calcium ion entry. Calcium ion entry. And is there any exit? Yes, of course, that is your potassium ion exit. Then we have phase 3. Then we have phase 3. Here potassium ion exit will occur. Potassium ion exit will occur. And phase 4 is the phase where there is a resting membrane potential is there. Till now all of us knew everything. Now I want you to focus here on learning one more thing, my dear students. That one more thing, see, during this time, whatever this time is there, so during this time, the blue line, we call this as ARP. What is that? ARP. What is ARP? ARP is nothing but absolute refractory period. Absolute refractory period. What is absolute refractory period? Can anybody tell me what is absolute refractory period? Absolute refractory period is very easy for you to understand. It means during this time, see, during this duration, you give any signal to the heart, give whatever voltage you give it to the heart, it is not going to listen. Means with whatever strength you give the voltage, the heart will not respond. Means during absolute refractory period, there cannot be entry of any new signal into the heart. Means during absolute refractory period, you cannot do anything electrical changes to the heart. We call this duration only as absolute refractory period. Absolute refractory period. That is the most important key, because to treat arrhythmia, okay, arrhythmia, we can do only one thing: either increase absolute refractory period or decrease the absolute refractory period. Either way you can treat arrhythmia, because if you decrease the absolute refractory period, the number of heartbeats is going to change, which will again prevent the entry of new signals. If you prolong the absolute refractory period, no entry of the new signals. So simple target is that to prolong or decrease the absolute refractory period, you are going to treat any arrhythmia. This is the most important key point which you need to remember for understanding your anti-arrhythmic drugs. So to treat arrhythmia, what do you need? You need to do one simple thing. What is that simple thing? To either increase the absolute refractory period or to decrease the absolute refractory period. Okay. So how can we increase or decrease the absolute refractory period? So please listen to me very carefully. These drugs. So we have the classification of the antiarrhythmic drug. What is that? Classification of the antiarrhythmic drugs. Sir, what is this classification of the antiarrhythmic drug? They are divided into class 1 antiarrhythmic drug. They are divided into Class 1 anti-arrhythmic drug. Then we have something called as a class 1A. In the class 1, we have 1A, class 1B, we have class 1C. Okay. So why class 1A, 1B, 1C? They're very important. You'll understand. My dear students, all the class 1A drugs. Okay. Absolute refractory period is the duration where heart will not respond to any signal given externally. You give whatever the strength of signal does not matter, but heart will never respond. So exactly, we are going to either increase the absolute refractory period or we are going to decrease the absolute refractory period to treat the arrhythmia. That's it. Okay. Got it? Got it? Someone wanted me to repeat that. That's why. Okay. So guys, listen to me. The next important thing, all the class 1 anti-arrhythmic drugs, they block sodium channel. They block sodium channels. They block, which is that? Sodium channels. They block, which is that channels? Sodium channels. But the class 1A drugs, what they're going to do? Of course, they will block the sodium channel. They will block the sodium channel. Along with the sodium channel, they also block potassium channel. They also block potassium channel. So these class 1A drugs act by two mechanisms. One mechanism is what? It will block the sodium channel. Another mechanism is what? It will block the potassium channels. Okay. Now, class 1A drug. Okay. Now class 1B drugs. What is that? Class 1B drugs. Now class 1B drugs, they block the sodium channels. They block the sodium channel and open the potassium channel. Look here. So why did we have 1A, 1B? Because one of them is potassium channel blocker. One of them is potassium channel opener. So that means they have, along with sodium channel blocking property, we have two different other properties. That is why we classified them into class 1A and class 1B and 1C based on their different mechanisms. Class 1C drugs block purely sodium channels. Class 1C drugs will block purely sodium channel. So what exactly we need to learn about these things? So first and most important, these are the class 1 drugs. Then we have class 2 antiarrhythmic drug. What are class 2 antiarrhythmic drugs? Of course, class 2 antiarrhythmic drugs are your beta blocker. There you are, beta blockers. So beta blockers work as a class 2 anti-arrhythmic drug. Okay. Now what about we have your class 3 anti-arrhythmic drugs? Class 3 anti-arrhythmic drugs, these drugs act upon the potassium channels. These drugs act upon the potassium channel. They block the potassium channel. Then we are left with the class 4 antiarrhythmics. These class 4 antiarrhythmic drugs, they are your calcium channel blockers. So when you look at classification of the antiarrhythmics, this classification is totally based upon their mechanisms. So first class for sodium channel blocker, second class for beta blocker, third are potassium channel blocker, fourth are calcium channel blocker. So sir, if we have this many classes, will we be able to remember this? Definitely I will make you people remember these drugs at one go itself. Especially most of you people get in the problem here only. The most important ones are here. Where are those? Class 1 anti-arrhythmic drugs. So once you understood the class 1 anti-arrhythmic drugs, then rest will be easy. Okay. Now, my dear students, let's understand about the class 1 anti-arrhythmic drugs. So when we need to understand the class 1 anti-arrhythmic drugs, so let's do one trial method here. Okay. So this was the original graph. Okay. Now I will block sodium channel. If I block sodium channel, which phase will be altered? 0, 1, 2, 3, 4. I'm blocking sodium channel. Which phase will be changed? In which area you can find the change? Phase 0, 1, 2, 3, 4, where you can find the change? Very good, in the phase 0. If it is occurring in the phase 0, means your phase 0 would look something like this, the new red one. Okay, see, to reach the same level of voltage, it took more time. The rest other will occur normally or not? Yes, of course, rest other will occur normally like this. So every time you blocked a sodium channel, if you notice here, what did you do, my dear students? You decrease the ARP. You decrease the ARP. If you decrease the ARP, that means the target is achieved. You treated a arrhythmia. So like this only, let's learn all the graphs related to all 1A, 1B, 1C. Okay. So let's start with the class 1A drugs. Class 1A drugs. So class 1A drugs, my dear students, what is the original graph? Original graph was something like this, which I am going to draw in the black color pen here. Okay. So now, class 1A drugs, they're blocking who and all? They're blocking. What is that? They are blocking your one of the most important ones, sodium channel, and along with that, they are also blocking potassium channel. So what is going to happen? Let's see the new one. Let's draw it with the green color. Now sodium channel is blocked, so phase 0 is altered. Okay, sir. Now the graph was going like this. Now phase 3, that phase 3 potassium channels also blocked. So potassium channel blocks means again it will lead to change like this. When you look here, what happens? The newer one is a green color, that is your ARP. Okay, so don't go to imagination on the graphs also, please. So what exactly I'm telling you, people? Phase 1 drugs blocked sodium channel. So first one, here is the alteration. Then potassium channel is blocked. Here is the alteration. So this is the story of your, what is that? That is your potassium and sodium channel blockade. That is caused by which drugs? Caused by your what is that? That is your class 1A drugs. So class 1A drugs, what are the drugs we have? We have a drug called as disopyramide. What is that? Disopyramide. Okay. Now you might be thinking, sir, all these drugs, why don't we take from one class only? No, we cannot take from one group of drugs and put it here, because drugs from different mechanisms. Some anti-epileptic would have blocking property, some local anesthetic would have blocking property. So based on their mechanism, we classified them into class 1, class 2, class 3, class 4. So that is the reason antiarrhythmics become difficult, because all the drugs from different places will come. Okay, disopyramide. Okay, we have one more drug that is called as procainamide. What is that? Procainamide. Sir, procainamide is what? Sir, procainamide is a type of a local anesthetic. Okay. Then we have one more drug, that is your quinidine. What is that? Quinidine. Okay. Quinidine. Okay. These are the drugs which you need to understand. What is that? That is your what is that? That is your procainamide, quinidine, and disopyramide. Sir, how do I remember it? Sir, I remembered it with a mnemonic like this: double quarter. And what is the currency used in England? What is the currency of England? What's the currency of England? Currency of England. कुछ तो बोलो यार. Currency of England is a pound. Currency of England is pound. So for pound, for a, okay. So what I'm going to do? D for disopyramide, Q for quinidine, P for pound. That is your procainamide. Like this, you can remember. Okay. So this story, we will go in a different manner. Just for now, remember, this is the mnemonic for each of them. I will teach you a way to remember everything in order after I teach 1B, 1C. Okay. Now, these are the drugs we have. Then, my dear students, first thing, what we are going to learn is graphs. Okay. After graphs and names of the drugs, then we will go to their users. Okay. Now, 1B drugs. My dear students, 1B drugs, they were blocking the sodium channel and open the potassium channel. If they're opening these things, what exactly you need to learn? So first thing, this is the original graph. Of course, we know that. Okay, so please tell me one simple thing, guys. If you open a channel, just think about this. Okay, you open the potassium channel. You opening the more potassium channel, the process, whatever potassium channel used to occur, it will occur before. Means, see, normally it was going like this. If I open the potassium channel, whatever process which is occurring now, it will occur before. It will occur before. So that will lead to narrowing of the absolute refractory period. Okay. So what I'm trying to tell you people is that if you open a channel, the process will come earlier. If you close a channel, process will come later because it will need more time. That's it. So what is going to happen? Let's see. Okay. So here what happens? You are blocking a sodium channel. So of course, phase 0 will become prolonged. Okay. Okay. Now it was going like this, but you also opened the potassium channel. So what will happen? Phase, whatever your phase 3 was there, which will occur earlier. So when you compare to the original and the newer absolute refractory period is being decreased. If you decrease the absolute refractory period, you are treating a arrhythmia. Okay. Now, look here. The second one. What is that? The second one group of drugs are your class 1B drugs. Class 1B drugs. So these class 1B drugs, we have lignocaine. Okay. Apart from lignocaine, we have mexiletine. Okay. Then we have what is that? That is your phenytoin. Okay. Now, my dear students, even if you forget the phenytoin, no problem. But here, lignocaine and mexiletine are the most important antiarrhythmic drugs which you need to remember. So, how I used to remember it with the help of a mnemonic, that is lettuce and mayonnaise. What is that? Mayonnaise. So, just remember L for lignocaine, M for mexiletine. So, how to remember these things also, I'll tell you which one will come first, which one will come second, what is the order, everything I'll tell you. Okay. Now let's go to the next group of drugs, that is your class 1C drugs. What is that? Class 1C drugs. When you are learning about class 1C drugs, they have no effect on other channel. They will block sodium channels only. So graph would look something like this. So this is original graph of our ventricular depolarization. Now what happens? The newer graph would look something like this because sodium channel activity is delayed. Rest other no change. Rest other will come to its original state like this. So this one will narrow the ARP. It will decrease the ARP. If it is decreasing the ARP, that means arrhythmia will be treated. So that class 1C drugs. What is that? Class 1C drugs. My dear students, we have a drug called as flecainide. What is that? Flecainide. What is that? Flecainide. Okay. Apart from flecainide, we have one more drug, that is propofol. What is that? Propofol. Okay. Propofol. Okay, propofol. So these other drugs which you need to understand. So for this also, to remember a trick, we have price please. Okay, sir, how to remember these three drugs? Okay, so how to remember these all three groups of drugs is very easy. We will start with that story. Okay, so all of us are FMGs. सब लोग जो बैठे हो FMGs हो ना? So you people, most commonly available food for us abroad, most commonly available in every country. Which food? Burgers, pizza and burgers. Okay, so remember this. Now let's start. Now I have a person who went to England. He went to England. In England, they have a premium whiskeys. A very nice distillery, a very quality whiskeys, a very premium whiskeys are available in England. So this guy decides to go out. So he decided to go out. He go to the shop and he will ask, so give me 2 quarters, take the pound. So he'll give 1 pound, takes the 2 quarters. He'll give 1 pound, takes the 2 quarters. Now he will drink both quarters of whiskey. After drinking both quarters of whiskey, now he will get hungry. He'll get hungry. Of course, see, he went, drank. Now immediately what he needs? Food. Now he will go to make McDonald's. In the McDonald's, he will order for a chicken burger. In that, he will tell, I want more lettuce and mayonnaise on my burger. More lettuce and mayonnaise on my burger. After the server gives the burger, now he tells, give me my fries. Give me the fries, please. Like that, in an order you can remember. So he went, he drank double quarter for a pound, class 1A. Class 1A. After that, he goes to a burger shop. He buys a burger. So for burger, he wants more lettuce and mayonnaise. So he tells more lettuce and mayonnaise. Now he will go to where? He will go to the same place and ask for, I want fries to eat after the burger. So the class 1C will be propophone. So if you remember the order, first he will drink, then he wants food. In the food, he will start with burger, ends with fries. So in this order, if you remember, it will be very easy. So can you people repeat it with me when I do this? Double quarter for a pound. Double quarter for a pound. D for, yeah, you people should be repeating. D for, everybody should be repeating at your own place also. Mike's muted also, please repeat. D for diisoparamide. D for diisoparamide. P for double quarter, Q for vinidine, Q for vinidine, P for procainamide. Remember, procainamide is first drug which comes. Then my imaginary story, this person went into England. He went into McDonald's. He asked for fries, please. Sorry, that is lettuce and mayonnaise on my burger. Lettuce and mayonnaise on my burger. L for lignocaine, M for mexiletine. Then he'll go to the same server and tell, give me my fries, please. F for flecainide, P for propophone, P for propophone. Everybody, will you remember all the class 1 antiarrhythmic drugs now? Everybody, will you remember? Easy. Can I consider everybody understood? हाँ या ना तो बोल दो यार, इतना मेहनत करके अच्छे से बना के तुम लोगों को बताया हूं. हाँ या ना तो बोलो. Okay. चलिए. Now, what I'm trying to tell you people, that is your class 1 antiarrhythmic drug. So let's go to the next important aspect. What is that? That is your, my dear students, I will go into the class 3 antiarrhythmic drug. Sir, आपका दिमाग से हटका हुआ है क्या? अरे 1 के बाद 2 आता है ना. सुन लो जरा, सुनो, सब्र करो, क्योंकि क्या होता है, when I'm talking about class 2 and class 4 antiarrhythmic drugs, these 2 and 4, they work in the same location, and 3 and 1 work in the same location. That is why I usually go to class 3 antiarrhythmics. Okay. So class 3, रुको जरा, सब्र करो, class 3 पढ़ लेते पहले. So class 3, they block up. Yes, sir. Potassium channels, sir. Of course, if they block the potassium channel, which phase will be prolonged? The potassium channel blockage will lead to which phase prolongation? Which phase is prolonged? 1, 2, 3, 4. Potassium channel blockade will lead to which phase prolongation? Most importantly, that is phase 3 prolongation. Very good. Why phase 3 prolongation? Because phase 3 is repolarization. Repolarization to occur, which ions are required? Potassium ions are required. Which ions are required? Potassium ions are required. So if at all, if you people did not understand this, now we will understand it very clearly. So look here, look here. So this is the graph which I want to tell you. So what happens? Originally, my depolarization curve used to look like this. Okay, phase 0, 1, 2, 3, 4. Phase 0, 1, 2, 3, 4. Now, when I look here, so this potassium channel blockage is there. So these drugs will actually, everything would be going the normal way. But during the time of phase 3, so potassium channel are blocked. So phase 3 will take more and more long period of time, leading to the prolongation of your absolute refractory period. So if ARP is increased, we are treating the arrhythmia. Okay. So what are the drugs we have? So please listen to me. We have a drug called as Amiotron. What is that? Amiodorone. Okay, amiodorone is different from amiloroid. Amiloroid is a potassium sparing diuretic. Amiodrone is a anti-arrhythmic drug. Amiodrone is a anti-arrhythmic drug. We have one more drug that is called as bretylium. What is it? Bretylium. Okay. Okay. Then we have one more drug called as dronadrone. What is that? Dronadrone. So look here, amiodorone and dronadrone. But sadly, one confusion problem comes. You usually beta blockers are which class? I told you people already, class 2. But rather than being class 2, here there is one beta blocker. There is only one beta blocker which will come under class 3 majorly. That is your sotalol. That is your sotalol. This is one special beta blocker which is having a class 3 anti-arrhythmic property. Class 3 anti-arrhythmic property means it is beta blocker also and class 3 anti-arrhythmic also. This is one special anti-arrhythmic drug. What is that? Special anti-arrhythmic drugs. So we have class 3 anti-arrhythmic drugs. Their working is like this. Here I want you to write down about amiodrone. Can anybody tell me what is amiodrone speciality? What is this amiodrone does? Amiodrone is a very important drug. My dear students, usually amiodrone should block which channel? Which channel should be blocked? Sodium, potassium, chloride, calcium. Which channel should be blocked? Amiodrone should block potassium channel. Of course, amiodrone should block potassium channel, but rather than that, amiodrone also block. See, it is not just potassium channel, also block other channel also block sodium channels. It also blocks potassium. See, potassium anyways it is blocking. It also blocks the sodium channel, even to a extent that it will also even block a calcium channel sometime. So the strong properties for potassium channel, but weakly it will affect the other channels also. That much important drug. Sir, is it only about amiodrone? Yes, this is a special drug. Is it only that much specialty? No, it is even more special drug. This drug, iodine containing drug. It is a iodine containing drug. Iodine containing drug. What is this iodine containing drug? Means whenever a person takes a amiodrone, what is going to happen? This amiodrone will go into the body. It will do its mechanism of action, but also release the iodine. It is also releasing the iodine. If it releases some free iodine, that means can it alter the thyroid profile of a person? Yes, of course, it can absolutely alter the thyroid profile of a person. So please remember this iodine containing drug. This drug can lead to hypothyroidism or hyperthyroidism, which can never be predicted. Hyperthyroidism, it can lead to either way, either of them, hypo or hyperthyroidism. Apart from that, it will cause peripheral neuropathy. What is that? Peripheral neuropathy. What is that? Peripheral neuropathy. Okay. Apart from the peripheral neuropathy, it will also cause pulmonary fibrosis. What is that? Pulmonary fibrosis. Pulmonary fibrosis means it is a type of restrictive lung disorder. Pulmonary fibrosis. See, look here. It is such a miraculous, fabulous drug because it is having multiple mechanisms at the same time. So many unknowing problems also. Okay. So is it only pulmonary fibrosis? No, it does not end here. It will also cause a corneal precipitate or corneal deposits, you can say corneal deposits. So corneal deposits occur means a drug will get metabolized. Some metabolites will go and accumulate in the cornea of your eye. So that means it is a very, very dangerous one. It is a very, very dangerous drug to be used. So please be ready with this. Amiodrone is a very important one. It will also cause my patients to have a photosensitivity. Photosensitivity means whenever person is taking amiodrone and if he will go to the sunlight, immediately person will develop a rash. So all these are the side effects. Associated with your amiodrone. So these many side effects, if it is there, that means there is a high likelihood there can be a MCQ. So all these are a very important side effects associated with amiodrone, Everybody clear so far? हाँ या ना बताओ? Yes or no? Bored? Timing. So are you guys bored or understanding, right? Okay. So let's continue. Let's continue. Once we understood about both. So you understood also, you are bored also with the Amiotron and this antiarrhythmics. See, antiarrhythmics are not so difficult. When you look at antiarrhythmics as a whole, so it's very simple. They are blocking some channels. And which channels they are blocking, you need to remember. That's it. Okay. Now let's continue. Let's go to the class 2 antiarrhythmic drugs. Class 2 antiarrhythmic drugs such as atenolol, Okay. Apart from atenolol, we have drugs such as metoprolol. We have drugs such as metoprolol. Guys, 1 second. Just give me 1 second. Guys, I'm really sorry. There was someone shouting at the door, so I had to go and look at it. That's why. I'm really sorry. I'm really sorry. We have beta blocker. Beta blockers are doing what? Atenolol, metoprolol, yes or no? We have even sotalol. Yes, of course. Sotalol also a beta blocker. Now, what is this class 2 antiarrhythmics does? Okay. Basically, they inhibit or they antagonize beta 1 receptor. They antagonize beta 1 receptors. If they're antagonizing the beta 1 receptor, that means they will decrease the heart rate. That is the reason which we are going to use. That is class 2 antiarrhythmic drugs. So class 2 antiarrhythmic drugs are used for what is that, my dear students? Any tachyarrhythmia. Wherever heart rate is increased in an arrhythmia patient, there you can consider giving a beta blockers. Then we have class 4 antiarrhythmic drugs. These class 4 antiarrhythmic drugs, they are calcium channel blockers. So calcium channel blockers are divided into how many types? Calcium channel blockers are divided into how many types? 2 types. What are those 2 types of calcium channels? So calcium channel blocker, dihydropyridines and non-dihydropyridines. I told you people, dihydropyridines. What is that? Dihydropyridines are specifically working on the smooth muscle, but non-dihydropyridines specifically work on the heart. Yesterday I told you people, these are non-dihydropyridines. What is that? Non-dihydropyridines. Non-dihydropyridines, these drugs are used for the treatment. In the treatment of your arrhythmias, the drugs are diltiazem. What is that? Diltiazem. Apart from diltiazem, we have one more drug, that is verapamil. What is that? Verapamil. Okay. So we learned about all the classes of the antiarrhythmic drugs, but so far what we learned is the names. Now let's understand. Now let's get to the interesting part of the antiarrhythmics. For example, a patient is having atrial fibrillation. What is that? Atrial fibrillation. So atrial fibrillation is a condition in which what is the ECG change? No P wave, different RR interval. So which drugs you'll prefer among all the classes of antiarrhythmics? So this atrial fibrillation treatment can be done with the help of 2 groups of drugs, which are those beta blockers. Okay, beta blockers are equally effective to that of calcium channel blockers. So beta blockers and calcium channel blockers can be used together. They can be used equally, but not together. See, but not together. Why not together? Why not together? Because these 2 drugs will become a bad combination. The heart rate will go down so much that patient can die. So you might be thinking that, अरे patient को आ गया arrhythmia, कौन सी वाली? Atrial fibrillation. मैं क्या करूँगा? अरे see, if I give only beta blocker, I'll have to wait for its action. मैं क्या करूँगा? दोनों दे दूंगा, जल्दी काम करेगा. नहीं भैया, जल्दी तुम पहुंचा रहे हो पेशेंट को. क्यों? Both of them suppress the heart rate so much that the patient can go into bradycardia and die. So not together, but equally effective. So you don't have to worry whether you are choosing calcium channel blocker or beta blocker. You can choose either one of them, okay. Now for example, a patient with history of bronchial asthma, okay. I will come to that. History of bronchial asthma. This is a very interesting story. History of bronchial asthma. Patient with the history of bronchial asthma, presented to the hospital with complaints of palpitation. Okay. Now on ECG, no P wave, and different RR interval. Which is the best drug used? Which is the best drug chosen for this condition? Okay, everybody read the question. Till then, I'll give the option. Option A, lidocaine. Option A, lidocaine. Okay. Option B, sotalol. Option C, propranolol. Okay. Option D, diltiazem. Tell me. A patient with a history of bronchial asthma present to the hospital with the complaints of palpitation on ECG, no P wave, different RR interval. Which is the best drug chosen for this condition? So somebody says B. Okay, everybody is saying B. What about others? Only few people are telling. I want 16 people to be answered. So 2 people are saying D, 2 people are saying B, only 4 people and me. Only 5 of us are बैठ के पढ़ रहे. 6 लोग हो गए. Very good. Now guys, first thing. Whenever you get this kind of questions, how do you solve it? Okay, you should not rush. First thing. What is the diagnosis here? Diagnosis is very clear to us, sir. What is the diagnosis, sir? The diagnosis is atrial fibrillation, sir. Of course. Okay. Now, next important. Sir, there is a history of bronchial asthma. In a patient with bronchial asthma, propranolol can be given or not given. Propranolol is a non-selective beta blocker. Can you give a non-selective beta blocker, sir, to a patient who is having bronchial asthma? No, you cannot give, because these drugs will block beta 2 receptor also. Leading to bronchoconstriction. So you cannot use propranolol. You cannot use sotalol, because even sotalol has a property of beta 2 blocking. Okay, so lidocaine is not a best drug in this scenario. Only equally effective drug will be calcium channel blocker left out. So you need to look at a bronchial asthma history. So only if you had remembered a hospital, if the ECG changes, then you would be confused. You might mark propranolol, diltiazem, but you should not be confused here. It is very clearly stated that is your diltiazem, because there is a history of bronchial asthma, because bronchial asthma history is there. Everybody clear now? So if at all patient is having a history of bronchial asthma, would you choose a beta blocker or something that is calcium channel blocker? Calcium channel blocker would be preferred. So that is the thing which you need to understand. Clear? Everybody clear so far? Okay, so if you understood this, let's continue to the next aspect. What is that? That is, for example, a patient came to you with an arrhythmia, that is atrial flutter. Atrial flutter usually does not require treatment, so we don't write anything here. So we are going to skip it, because it does not carry any pharmacological value for us. Okay, but is there anything else? Let's talk about ventricular fibrillation and ventricular flutter. Ventricular flutter is also called as a ventricular tachycardia. My dear students, ventricular fibrillation would be something like this, ECG. Okay, but ventricular flutter, the ECG would look something like this. Sir, what you are telling us, I will tell you people, don't worry, it's very easy to understand. Guys, the first thing, Normally in the ECG, you have PQRST. So you remember QRS as a result of ventricular depolarization. First. So during ventricular depolarization, QRS was formed. Every time ventricle depolarizes, QRS wave will be formed. Okay. Now, in ventricular fibrillation, what happened? Two ventricles are sitting like this. Now, two ventricles used to contract together and relax. Contract, relax. But here, what happens is that the ventricle will start to do this dance. If ventricle will start to do this dance, will the blood go out of the heart or it will not go out of the heart? अरे नहीं जाएगा ना, क्योंकि ventricle तो ऐसा नाच रहा है. When ventricle नाचने लगेगा, even better way to remember, I used to tell fibrillation is like vibrating. That's it. Their ventricles are vibrating but not doing anything. Like that also you can remember. When ventricle is doing like this action, will you get a QRS? No, but you'll be getting any unnecessary wave. So if you didn't understand the shape of the ECG completely out of the blue, anybody, if I give you an ECG like this, what is this ECG? What is the diagnosis of this ECG? What is the diagnosis of this ECG? Of course, ventricular fibrillation. So what is this ECG then? Ventricular fibrillation. What is this ECG then? Ventricular fibrillation. So you cannot see any other wave, and whatever you are seeing also, all these are QRS complexes only, but same shape or different shape. QRS complexes are in a different shape. All QRS complexes will be in different shape. That is your ventricular fibrillation. Yes, this is a ventricular fibrillation ECG. Now, ventricular flutter, what happens? Ventricular flutter, ventricle contracts, agreed. But will it contract slowly or very fastly like this? So if ventricle contracts so fastly, all you can record is every time ventricle contract QRS, ventricle contract QRS, ventricle contract QRS. So your ECG machine cannot record anything else except for the ventricular contraction. So that time your ECG machine will give you only yes sir, QRS. When you look at these things, all of these QRS complexes are in the same shape or a different shape. Same shape. We call it as a monomorphic. Mono means single. Morphic means shape. Monomorphic QRS complex. Agar monomorphic QRS complexes mil gaya, that means it is a ventricular flutter. Okay, ventricular flutter ho, ventricular fibrillation ho. In both of these scenarios, what is the first step of treatment? What is the first step of treatment? First step of treatment, what will you do? Sir, ventricular fibrillation आया तो patient को लेके आऊंगा, ECG करवाऊंगा, लिटाऊंगा, बोलूंगा कि भैया तुझे ventricular fibrillation हुआ है, हम लोग ट्रीटमेंट के लिए सोच रहे हैं, ये सब करने तक patient का डेथ हुआ होगा. So you need to be very quick and very rapid to respond. So what is the first thing you are going to do? You are going to do cardioversion. What is that? Cardioversion. This cardioversion means, what is that? See, I can tell you simple. Cardioversion is to restore the original rhythm. Original rhythm में लाने के लिए, to get us into the original rhythm, what we need to do is two types of cardioversion. One with the help of our drugs, of course. Another one with the help of our most important thing. What is that most important thing? That most important thing will be your electrical. Very good. So electrical cardioversion. Electrical cardioversion is only called as a defibrillation. What is that? Defibrillation. Okay. Now defibrillation. Then next you can use the drugs. So drugs used followed by defibrillation. You are going to use the drugs. So followed by defibrillation, you are going to use the drug. The best drug for the ventricular arrhythmia is your lidocaine. Best drug for the ventricular arrhythmia is lidocaine. Lidocaine also, my dear students. And one more thing, it is also drug of choice. It is also drug of choice. In which condition? In the digoxin induced arrhythmia. What? Digoxin induced arrhythmia? Yes, of course. Digoxin induced arrhythmia means digoxin can also cause arrhythmias. Arrhythmias can also be caused by antiarrhythmics. See, look at this heading. We are using a drug to treat arrhythmia, and this drug itself, if you miss the doses, can itself cause the arrhythmia. So we need to be very careful. Okay. So digoxin induced arrhythmia. All right, VFIP, VTAC done. Okay. Then, my dear students, I want you to understand one more condition. There is one condition called as PSVT. PSVT. Okay. So, PSVT is a paroxysmal supraventricular tachycardia. How does PSVT ECG look like? So, it is very easy for us. PSVT ECG would look something like this. So now tell me in this, if you consider P, this is QRS T wave, where is the another P? Where is the another P? So in the PSVT, in the ECG, can you find out P wave or not? Here, see, normally your ECG will look something like this. Okay, P, QRS, T. Yes or no? QRS complex and T. Now, what is my question? What is my question is that where is P wave? Question option A, option B. Which is P wave? Take a guess. Which is P wave? You have A and B both. Under QRS complex? No. Just take a guess. Now, either take half of you say A, half of you say B. That's also fine. But I want you to tell some answer. That's it. So here the story is not about no P wave, present P wave, but rather see, you have P wave also almost similar shape. T wave also of similar shape. Here in PSVT, P wave and T wave both are overlapped. Both are overlapped. So you cannot even differentiate which is P wave, which is T wave. Okay, which is P wave and which is T wave, you cannot differentiate because the reason is both the waves are overlapped. So in the PSVT, what happens? There is an increased heart rate to the patient. Okay, on the ECG, P and T wave are overlapped. Okay, overlapped. Heart rate can go up to 200 usually. Up to 200, some cases it can go even bigger. Okay, in the patient, when they come to you with the PSVT, what is the treatment, my dear students? Treatment. So treatment, what you are going to do, see, if they ask you drug of choice, the drug of choice you are going to use is adenosine. What is that? Adenosine. Apart from drug, we do other manuals, such as Valsalva manure, that is Valsalva manure. Apart from Valsalva manure, we can also do one more thing called as carotid massage. What is that? Carotid massage. So these both can be done. In a patient with PSVT. Why we are going to do Valsalva and carotid massage? Because they both will trigger vagus nerve. Because vagus nerve is triggered, heart rate will decrease. So that is the problem. The problem is increased heart rate. And here P for paroxysmal means it happens regularly or sometime it will happen. So PSVT happens frequent, like some episodically. Whenever episodically occur, patient come to you with a palpitation, and when you do a ECG, P and T wave are overlapped with each other. So drug of choice for this condition is adenosine. Then we can use Valsalva and carotid massage to stimulate the vagus nerve, which will decrease the heart rate. And this is a story of your, what is that? PSVT. This is a story of your PSVT. Now, once you understood about this, the next important aspect which you need to understand, my dear students, that will be your other antiarrhythmic drug. Digoxin itself, digoxin is an antiarrhythmic drug. Of course, we just now learned one antiarrhythmic drug, that is your adenosine. Okay. Apart from adenosine, we have one drug, that is a IF channel blocker. What is that? IF channel blocker means funny current. See, life is very funny here. These funny currents are responsible for the action of your SA node. SA node will generate the signal automatically. If it is generating the signal automatically, this automaticity is maintained by your IF channel. IF channel blocker is called as ivabradine. What is that? Ivabradine. Now, what is the name of this thing is also called as funny channels, funny current channels. What is that? Funny current channels. So these funny current channels are the ones which are responsible for your automaticity of the heart. So on that, we can target our funny channel blocker, that is your ivabradine. Okay, then one important last thing, if a patient, a drug of choice for what is that? For the WPW syndrome. What is that? WPW syndrome. So drug of choice for the WPW syndrome is your flecainide. What is that? Flecainide. So flecainide belong to which antiarrhythmic drug? Class 1, 2, 3, 4. Class 1. Flecainide belongs to class 1A, 1B, 1C. Tell me now. Price, you wait in the starting or you wait at the end? You wait at the end. End means what? At the end of the class 1. End of the class 1 is who? Class 1. Very good. That is class 1C. Very good. That is your class 1C. This is a story of your all the drugs which are related to your cardiovascular system, which has to be most importantly studied. Okay. Everybody clear? Everybody clear so far? So if you understood so far, now take a small break, then we will continue the rest of the thing. We'll start with the central nervous system. Okay. Next, we are going to start central nervous system. So the time is, what is this? Asking everyone to join, please. So we shall start the CNS. CNS is a very interesting chapter, very interesting chapter. Okay. And as much as it is interesting, it is also very, like, yes, of course, cardioversion is nothing but obtaining into the same rhythm. So cardioversion has contained two types. Electrical cardioversion is called as defibrillation. Okay, chemical cardioversion is called as using the drugs. That's it. Clear? Drugs whichever we use lidocaine, for example. So any antiarrhythmic, if you are using, we are going to call it as a cardioversion only. Okay. So the drugs which we use are lidocaine we use, right? Like that. Any ventricular arrhythmia, first drug is lidocaine. First process is cardioversion, that is especially your electrical defibrillation. Got the point? Okay. So can I start, everybody? There is only 14 people now. What happened? I know some of the people who are in final years, they are having a classes today. But rest of you, please ask everyone to join quickly. All right, we shall start then. Okay. So central nervous system. What do you think of central nervous system? How many of you like central nervous system? How many of you hate central nervous system? How many of you feel central nervous system is difficult? So let's start with a very much interesting. What is this interesting thing? So guys, in central nervous system also, as I taught CVS, like that only, I will tell you about the diseases little bit. I'll give you a complete idea. Then I will try to go into the drugs. So far what I have done, that's what I want to proceed with. But if you people think, sir, we'll just do the drugs and mechanisms, we can do that also. Okay. But that won't serve the purpose of integrating the subjects. Even though you tell me not to, I will end up doing integration of other things here. Okay. So in the central nervous system, let's start with one of the very interesting thing. What is that? That interesting disease, Parkinson disease. What is Parkinson disease? Parkinson disease. टेल मी व्हाट इज पार्किंसन डिसीज। अरे सर कुछ तो है, हमें क्यों पूछ रहे हो, है ना? ऐसा तो नहीं चलेगा मेरा भाइयों। पार्किंसन डिसीज होता क्या है? उसको पार्क करना नहीं आता है क्या? बहुत गंदा जोक था ये, मुझे भी अच्छा नहीं लगा, ठीक है? Even I didn't like this joke. So Parkinson disease, what happens? Can anybody tell me? So Parkinson disease is an interesting disorder. There is a decrease of the dopamine. Okay. So what exactly is decrease of the dopamine? Listen to me very carefully. In Parkinson disease, so Parkinson disease is a decrease of dopamine, Where exactly dopamine is decreased? Decrease of dopamine in a place called as basal ganglia. What is that? Basal ganglia. Basal ganglia. So basal ganglion. Sir, basal ganglion, if dopamine is decreased, what is going to happen? You are going to get this disorder, Parkinson disease. Okay. So if basal ganglia dopamine is decreased, exactly in which area? Called as substantia nigra. Substantia nigra. So a dark area which is present in the basal ganglia called as substantia nigra, there one of the most important neurotransmitter is your dopamine. Now that dopamine will be decreased in the basal ganglia, leading to Parkinson disease. Okay. Now patient with the Parkinson disorder come to the hospital with the complaints. What are the clinical features we are going to get? So clinical features the person is going to get, my dear students, the first and most important thing, movements will be affected. So patient will have affected movement. So what is going to happen is that the patient will have hypokinesia. Okay, hypokinesia means decrease of the movements. Patient will have rigidity. What is this rigidity? So listen to me very carefully. These muscles, whatever is there, they easily should contract, relax, and do this. Okay. Now, but patient will end up having a hard, stiff muscles. Why stiff muscle? The reason is I'll come to that. The reason for this stiff muscle, the rigidity development, is because dopamine is one of the neurotransmitter which is responsible for the muscle tone controlling that will be impaired. Apart from that, patient will have most importantly tremors. Okay. Now in the rigidity, again, two types of rigidity is there: cogwheel rigidity and lead pipe rigidity. What is that? Cogwheel rigidity and lead pipe rigidity. Tremors, there are multiple types of tremors. When they're working, they're called as intentional tremors. See, when I ask a person to touch an object and see, I'm going like this, I should touch the pen, but see, I'm going like this, I should touch the pen. Instead of touching the pen, when I'm going, if I start to get tremors, so when I ask to do some activity and if I get tremors, we call it as intentional tremor. So even at rest, if my hand is having a tremors, we call it as resting tremors. Okay, so when I'm talking about intentional tremors, that is associated with cerebellar pathologies. So in Parkinson disorder, which type of tremors will be there? Resting tremors. What is that? Resting tremor. And flapping tremor is totally different thing. When you do this, the patient will have a flapping tremor. That's totally different thing. Okay, so these are some clinical features, and most importantly, all the extrapyramidal manifestations. Okay, so when we are talking about extrapyramidal manifestation, my dear students, we need to do the treatment of the Parkinson disorder. So treatment of the Parkinson disorder is very easy for us to understand. One of the most important thing is that increase the dopamine. Yes, if you increase the dopamine, you can treat the patient. Is there anything else? You can stimulate dopamine receptor. You can stimulate dopamine receptors in the CNS. Either way, you can treat the patient, because see, what happens is that, consider this is one nerve. This is one more nerve. Now here dopamine was released. This dopamine used to act upon the receptors. Okay, so the end summary is that if you increase the dopamine, it will go and stimulate the receptor possibility, or you can use the drugs. Directly stimulate the receptor. So two ways of treating the Parkinson disease: increase the dopamine activity or stimulate the dopamine receptors in the central nervous system. Central nervous system. So how are we going to do that? So for that to understand, you can think, sir, if there is a decrease of dopamine, we can give the dopamine directly. Now, so there is one big problem. So consider this is one blood-brain barrier. What is that? Blood-brain barrier. What is this barrier? Blood-brain barrier. So we have a blood-brain barrier. Now, what I will do, I will give a dopamine to the patient. I'll give a dopamine to the patient. Okay. Now, here we have, see, here we have the brain. In the brain, what is there, my dear students? Neuron is there. What is there? Neurons are there. Okay. So if you focus here and understand, there is a dopaminergic neuron. There is a dopaminergic neuron, blood-brain barrier, and here is the blood. Okay. Now, this dopamine, whenever I give, I ask him to cross the blood-brain barrier. He said, sir, I cannot cross the blood-brain barrier. I cannot cross the blood-brain barrier. Okay. So, if we cannot cross the blood-brain barrier, what exactly other things we need to understand? So, please understand, guys, it's very easy. So, what I will do, instead of dopamine, I will give something called as levodopa. What is that? Levodopa. Now, this levodopa is a chemically altered structure. Levodopa will cross the blood-brain barrier. Okay. Now, levodopa will cross the blood-brain barrier. Levodopa will cross the blood-brain barrier, and this levodopa will become, my dear students, called as dopamine. Now it will go and stimulate the dopamine receptors which are present. Okay. So this levodopa to dopamine conversion is done by an enzyme called as dopa decarboxylase. Dopa decarboxylase. That is only called as dopa decarboxylase. So dopa decarboxylase is present in the central nervous system also. Dopa decarboxylase is present in the periphery also. Now, see, think about this. I gave a levodopa. After I gave a levodopa can directly get the effect of peripheral dopa decarboxylase. See, in the blood also, dopa decarboxylase is there. Brain also it is there. So if you give the drug into the blood, immediately levodopa will get converted into dopamine. If it gets converted into dopamine, then dopamine cannot cross the blood-brain barrier. Of course, means I need to block this enzyme dopa decarboxylase with the help of a drug carbidopa. Now, listen to me. I blocked the peripheral dopa decarboxylase. Now, levodopa cannot get converted into dopamine in the blood vessel. Now, levodopa will go into the brain. In the brain, we have again dopa decarboxylase. That dopa decarboxylase will convert levodopa into dopamine. Now, dopamine activity can be achieved. So, that is how we are going to use levodopa and carbidopa. Now, apply the logic and tell me, carbidopa, should it cross the blood-brain barrier or it will not cross the blood-brain barrier, carbidopa? Yes or no? Carbidopa should cross the blood-brain barrier or it should not cross the blood-brain barrier? Think and tell me. It should not cross the blood-brain barrier. See, if carbidopa will also come into the central nervous system, then whole romance will become spoiled. Because the romance is what? The romance itself is here to inhibit peripheral dopa decarboxylase and to save the central dopa decarboxylase. So carbidopa, will it cross the blood-brain barrier? No, sir, it won't cross the blood-brain barrier. So only peripheral action is for carbidopa. That is the story. Very good, everybody. Very good. You people are following very nicely. Now, when you're looking at this one, please understand this dopamine. Now, this dopamine can be metabolized by two enzymes. What are the two enzymes? One of them is monoamino oxidase, MAO-B. So monoamino oxidase has subtypes MAO-A, MAO-B, MAO-A and MAO-B. MAO-A affect the metabolism of serotonin. MAO-B will affect the metabolism of dopamine, and it will also be affected by metabolized by one more enzyme called as COMT. Now dopamine will become into the degraded. So what I'm trying to tell you people is that dopamine can be metabolized by can be damaged by two enzymes. One enzyme is MAO-B and another one is COMT. So what exactly we need to understand? So it is very easy for us. First group of drugs for the dopamine, that is Parkinson disorder, a combination of levodopa and carbidopa. Now levodopa and carbidopa, this carbidopa will cross the blood-brain barrier or no? There is no crossing of the blood-brain barrier. No BBB crossing. Okay. Then next thing what I can do? The next thing what I can do is very easy for us to understand. My dear students, please understand what is that. That is your, look here, MAO-B inhibitor. What is that? MAO-B inhibitors. So if I inhibit MAO-B, see, listen to me, dopamine was there. Dopamine used to be metabolized into its degradation products by the enzyme MAO-B. Okay, now if I block this MAO-B, automatically dopamine will be increased. So that is what is the treatment which we wanted. So MAO-B inhibitors, my dear students, we have drugs called as selegelin. What is that? Selegelin and rasagelin. What is that? Rasagelin. Selegelin and rasagelin are the two drugs. Gelins are the ones which are MAO-B inhibitor. Okay, my dear students, the next one we can use, that is your COMT inhibitors. Same thing I told you people, dopamine used to metabolized into degradation products by one more enzyme called as COMT. The COMT is nothing but catechol O-methyl transferase. It will break down all the catecholamines. So if I inhibit COMT, dopamine level will be increased. We have drugs such as entacapone. What is that? Entacapone. Okay, entacapone. Apart from entacapone, is there any other drug? Yes, we have one more drug called as tolcapone. What is that? Tolcapone, my dear student, tolcapone, do we use it anymore? We don't use it because it is hepatotoxic. Very toxic to the liver. That is why we don't use this drug anymore, because of this hepatotoxicity that is caused by your tolcapone. What is that? Tolcapone. We have two drugs, entacapone and tolcapone. Okay. Now, my dear students, we can do one more thing. What is that? Directly stimulate the dopamine receptor. That is only your dopamine agonist. But dopamine agonist means dopamine receptors are located where? Dopamine receptors are how many types? Dopamine receptors are divided into two types. One of them is called as D1 receptor. Another one is called as D2 receptor. So please understand, dopamine 1 and dopamine 2. Dopamine 1 receptors are located where? They are located in the periphery. So if they are located in the periphery, means they are located outside of the brain. Inside the brain, we have that is D2 receptor. In the brain, predominant receptors are D2 receptors, my dear. Okay, which is that D2 receptors. So when you are talking about dopamine agonist, these dopamine agonists, we have drugs such called as, these dopamine agonists can be further divided. So basically, first thing, they stimulate which receptor? D2 receptor. D2 receptor. Dopamine agonist can be divided into ergots. One of them is ergots. So ergots are a group of chemical from which we are getting the drug. Ergots are good for body, are also they're also involved in some places. See, ergots actually they're used as a treatment also, but these ergots can also cause a poisoning. These ergots can also cause poisoning. Okay, but these are ergots are derived from the naturally occurring substances. Okay, so how we have some fungus which is danger to us, but from fungus we can take antibiotic. Now, like that only we are taking it from a ergots. Okay, now these ergot plants, we have drugs. What are the drugs we have, my dear students? We have a drug called as bromocriptine. What is that? Bromocriptine. What is that? Bromocriptine. Apart from bromocriptine, we have one more drug called as pergrolide. What is that? Pergrolide. Okay. Now, among these, which is the most important drug to be remembered, sir? You need to remember the bromocriptine, sir. Bromocriptine is a very important drug. Okay. Apart from that, we have one of the most important, very important drug. That very important drug is your rotigotine. What is that? Rotigotine. What is that? Rotigotine. Rotigotine is a very important one because it is the latest drug. It is the latest ergot derivative drug. What is that? Latest ergot derivative drug. It is available in the form of transdermal patches. In the form of transdermal patches. So what is this? So please understand what we are going to do. We will put a ergot containing patch, and this patch will release the drug continuously, so that in the blood the quantity of the drug will be maintained in a normal level. So this is one of the most important thing, that is your rotigotine. Rotigotine is a very important drug that was asked recently, and is a recent drug which is available in the form of a patch. Clear, everybody? Then we have non-ergots. Non-ergots. Somebody already told me the non-ergot derivatives. We have a drug called as cabergoline. Okay. We have a drug called as ropinirole. What is that? Ropinirole, not rock and roll. Ropinirole. What is that? Ropinirole. And we have one more drug. That is your pramipexole. What is that? Pramipexole. We have a drug called as pramipexole. So all these drugs are your non-ergot derivatives. These non-ergot derivatives are basically your cabergoline, ropinirole, and pramipexole. And we have ergot derivatives: bromocriptine, pergrolide, and rotigotine. These are the drugs which we have for the treatment of Parkinson disease. Apart from that, my dear students, one drug is there that is called as amantadine. What is that? Amantadine. Can anybody tell me what is amantadine actually? Amantadine is an antiviral drug. So this is why you people hate us, the MD pharmacologist, the most. You people hate MD pharmacologist as most because of these particular things. Okay, sir, antiviral you are telling, like a dumb person, you're getting it into Parkinson. So these situations are inevitable because drugs are chemicals. So chemicals can have multiple properties and multiple ways it can react with the body. Cabergoline. Okay. Cabergoline, guys, please add cabergoline into ergot derivatives. Please add cabergoline into ergot derivatives. Okay. I'm really sorry. Add cabergoline into ergot derivatives. I'm sorry. Yeah. Thank you. Yeah. Cabergoline is a ergot derivative. Yeah, you're right. ओके भाई, ऐसा मत सोचना कि सर को कुछ नहीं आता है, कभी कभार फ्लो में आगे पीछे हो जाता है। आई एम सॉरी फॉर दैट। पीछे से कोई बोल रहा है कि यार मजा आ गया, अब तो छेड़ेंगे सर को, है ना? ऐसा कुछ नहीं, एवरीबडी डज इन फ्लो स्मॉल थिंग्स। ऑलराइट, कैन आई कंटिन्यू? कुछ तो बता दो यार, कैन आई कंटिन्यू? पक्का ना? चलो लेट्स सी. So what I'm trying to tell you people, amantadine is an antiviral drug. What it will do, it is an antiviral drug, but see, you had neuron, na? You had neurons here, na? Dopamine neuron. So basically amantadine, dopamine, whatever was there, na, its availability will be increased. The availability of the dopamine will be increased. But how it does? Only amantadine knows. He never called me and told. He never told anybody. But it is a unknown mechanism. What it does is it increase dopamine availability. It increase the dopamine availability. So this is a story of your anti-Parkinson drugs. Okay, so among these things, bromocriptine, cabergoline, rotigotine, and all these things. So please remember, cabergoline is one of the long-acting drug. Okay, now bromocriptine. About bromocriptine, I taught you people in diabetes. About bromocriptine, I taught you people in one more disease related to brain. Sir, already इतना drugs आ चुके हैं कि brain काम ही नहीं कर रहा. आप बोल रहे हो brain के related. That is in a disorder called as prolactinoma. That is in a disease called as prolactinoma. Okay. So once we finished about Parkinson disorder, let's go to your favorite drug. Anybody? That is your opioids. That is your opioids. Sir, what are these opioids? Sir, opioids are very interesting ones, sir. Yes, cabergoline is the best drug used in prolactinoma because it is a long-acting drug. I told you people about prolactinoma and prolactinoma. We can use both bromocriptine and cabergoline, but cabergoline is a longer-acting drug, so we choose it over bromocriptine. Okay. Now, opioids. Guys, opioids are very interesting ones. So, opioids are coming from where? Batao, ye mat bolna ki sir Rajasthan se aata hai. First thing, tell me, anybody from Rajasthan here? Any person from Rajasthan? Online classmate? No one? Okay. No worries. So because if someone is there, poppy plants aata hai. Very good, very good. Poppy plants aata hai. So listen to me. These opioids are usually, my dear students, we can classify opioids into very, very different ways based on their mechanism, based on the source. Hanji, agar opioids ke बारे में सुने होंगे, तो अफीम करके आता है. There is something called as AFM. So basically, AFM, you people might have heard about AFM. This AFM is a plant-derived alkaloid. This plant-derived alkaloid from a plant called as poppy plant. Now, this alkaloid is processed and made into small black color pellets, which many old age people and who are addicted to AFM will put it in the chai and drink it. अरे भाई थोड़ा अफीम खा लिया अब तो मेरे शरीर को सुकून मिल गया. So that type of thing you might have been seen. Okay. Now when we are talking about opioids, the first old opioids, the source of the opioids is poppy plant. Now, when you're talking about poppy plant, now poppy plant is a source, agreed. So if poppy plant is a source, now this poppy plant is giving you something called as alkaloids. Poppy plant gives something called as alkaloids. Now these alkaloids are the ones which are responsible for opioid action. Okay. Now, when you need to understand about opioid, now these opioids have some receptors. Even before going there, we have something called as endogenous opioids. What is this endogenous opioids? Tell me. Endogenous. Endo means inside the body. Inside your body itself, there are some opioids which are present. We call them as, my dear students, endorphins. What is that? Endorphins. So basically, endorphins are the endogenous opioids. So if you understood about this, we have some opioid receptors. So what is this opioid receptors, sir? So opioid receptors are the most important one. They are located in multiple parts of the brain, many areas of the brain. Okay. If they are located in the many areas of the brain, let's understand the types of the receptor. They are divided into kappa. Then we have one more type of receptor, that is mu receptor. Then we have one more receptor, delta receptor. Okay. Now, Opioids come from a plant called as poppy plant. They produce alkaloids. These alkaloids work as opioids. Then endogenous opioids are the ones which are called as endorphins, Okay. Then opioid receptors are divided into kappa, mu, and delta. Okay. Now, when I'm talking about kappa, mu, and delta, please understand whenever I stimulate delta receptor, it will produce an effect called as an analgesic effect. What is that? Analgesic effect. What is that? Analgesic effect. So what is this analgesic effect, sir? This analgesic effect means to decrease the pain, Wow, nice. So this pain decreasing effect can be achieved by the stimulation of your delta receptor. Okay, then my dear students, let's understand the most important one, mu receptor. Whenever I stimulate a mu receptor can lead to physical dependence. What is that? Physical dependence. What is physical dependence? Dependence means what? Physical dependence means what? So physical dependence is nothing but addiction. When they stop the substance, they will develop the physical symptoms. You might have noticed the alcoholics, no? Those who drink alcohol for years together, those who are completely dependent on alcohol, if you stop alcohol to them, immediately they will start to tremor. They will start to tremor because of why? Because their body is dependent on alcohol so much that if they don't drink alcohol, immediately their hands will start to shiver. So that is type of addiction is only called as physical dependence. Okay, it will also cause a meiosis. Meiosis means what? Dilated pupil or contracted pupil? Contracted pupil. What is that? Contracted pupil. These people also cause constipation. What is that? Constipation. Okay, now apart from the constipation, we have analgesic effect. Look here, sir, analgesic effect is seen by whom? It is seen by both of them. What is that? That is your, very good, that is your analgesic effect by delta receptor and mu receptor also. Now even when they are stimulated, they will also cause respiratory suppression. What is that? Respiratory suppression. So respiratory suppression is a good thing or very bad thing? It is very bad thing. So you people might have heard people who will overdose on opioids in movies and all. The person died of overdosing heroin. Heroin is an opioid. Now this guy overdosed on the heroin. Once he overdosed on the heroin, this heroin will kill the person because of the respiratory suppression. Okay, now apart from that, it will give euphoria. What is that? Euphoria means what? Extreme feeling of happiness. Then he will go to sleep. That is only called as sedation. So all these effects can be achieved by your mu receptor. Sir, how can we remember this many? We have one standard mnemonic used by among many faculties, that is your PM cares. Okay, so that is why I went in that order only, so that you can remember. You just remember the mnemonic PM cares. That effect will be achieved as a result of mu receptor. Then you are talking about kappa receptor. Kappa receptor will impair the sleep, causing dysphoria. It will cause dysphoria, which is not so great or important for you. Okay, so what we need to understand? So we need to understand, my dear student, these opioids, whatever is there, they're very interesting. What exactly is that? We have classification of the drugs. This classification of the opioids, and along with that, we will learn about the uses also. The first classification, my dear students, we call them as agonist. Agonist means what? They will stimulate the opioid receptor. They stimulate the opioid receptor. Opioid receptor. If they're stimulating the opioid receptor, means you are getting these effects such as physical dependence, meiosis, constipation, analgesia, respiratory suppression, euphoria, and sedation. All these effects can be achieved. So with this much being said, let's understand about the agonist. So when you're learning about opioid agonist, we have drugs such as morphine. Okay. We have drugs such as codeine. What is that? Codeine. Okay. Now, apart from morphine and codeine, is there anything else? Yes, my dear students, that is only called as fentanyl. What is that? Fentanyl. Okay. Apart from fentanyl, do we have anything else? Can anybody tell me, is there anything else? We have one drug called as pethidine. Sir, morphine, codeine, fentanyl, pethidine. Among these, which one is a prototype drug? Prototype drug means what? Prototype drug. Prototype drug means, see, when I use morphine, I will get all the effects as a result of opioid receptor. See, I will get physical dependence also, meiosis also, constipation also, analgesia also, respiratory suppression also, euphoria also, sedation also. All these effects can be achieved as a result of one drug, that is morphine. So one drug give all the properties of that particular group, means you can add it into a group called as prototype drug. And morphine is a natural drug or an artificially made drug, synthetic drug? It is a natural drug. This is a natural drug. Okay. Now, natural drug means directly it is derived from the poppy plant alkaloid. Okay. Sir, what about codeine? My dear students, codeine will cause one of the most important thing. It will cause cough suppression. This is one of the very interesting property about codeine. But codeine, is it available in the market today? Can you prescribe codeine to someone? In the examiner, agar aap logon ko problem mein fasana chahta hai, he will ask, can you prescribe codeine or not? Can you prescribe codeine or not? Yes or no? कुछ तो बोलो यार. ఏమైనా చెప్పండి. Codeine is what? Codeine is prescribed or not prescribed? Codeine used to come in a syrup called as Corex. This Corex syrup, see, listen to me, any situation, be it cough, be it no cough, be it dry cough, nowhere we use it in the practice today because it causes severe addiction. Because of that, India and many other countries, everywhere it is being banned. It is being banned from the usage of this drug. Okay, banned. Now, codeine causes cough suppression. So earlier time we used it for dry cough. Okay, earlier time we used it for dry cough. Now, fentanyl. What is this fentanyl? Fentanyl is one of the most important thing. If this exact question, exact line to line word they will ask, this is the most potent opioid. Why you need to understand this is the most potent, means among all the opioids, which is the strongest opioid present, my dear students, strongest opioid present will be your fentanyl. And this fentanyl is available in the form of a patch form. Means already I told you rotigotine, where you can put transdermal patch. Fentanyl patches are also available. So this is one of the most important thing. So opioid agonists, sir, where do we use them? Can anybody tell me opioid agonist usage in the patient with a myocardial infraction? What is that? Myocardial infraction. Where do we use it? myocardial infarction, to pain management, to do the pain management, For if there is a severe pain management, we can use what is that? That is your opioids. Where else we can use? My dear students, in the cases of trauma management, in the case of trauma, who is having a severe pain, we can use them. Okay, during the time of surgeries, especially before pre-anesthetic medication of the surgery, before starting the surgery, to supplement the analgesia, we can use opioids. Opioids can also be used in the cancer pain management. What is that? Cancer pain management. So in the stages of cancer, we'll have a severe pain, and the best drug used here is fentanyl. That is your fentanyl. Okay, the best drug used is fentanyl because it's the strongest opioid. It is more stronger than your, what is that? More stronger than your morphine and any other opioid present. But this fentanyl is an artificial synthetic opioid. So myocardial infarction, earlier times what they used to do, for example, some people used to sell heroin drug market, like black market, illegal drug sellers. They used to sell heroin. When they're selling heroin, along with heroin, they'll mix fentanyl. Okay. The mixing of fentanyl and heroin used to be so strong that patients used to die by taking one single dose also. That much dangerous opioids, and numerous hundreds and thousands of people died because of the fentanyl dose mismatch. Okay. So please understand. Okay. Now, where else we can use? My dear students, these drugs are also used in a condition that is your pulmonary edema. Pulmonary edema, especially which drug is used in the pulmonary edema, along with your loop diuretic, morphine can be used. Along with loop diuretic, morphine can be used because it prevents the frothing. Okay. Now, guys, please understand the next important aspect. We have something called as mixed drugs. Mixed drugs means what, sir? Mixed drugs means they're both agonist and antagonist. What do I mean by this agonist antagonist? Means I have three receptors: mu receptor, kappa receptor, and delta receptor. For example, one drug X is there. This drug X is agonist to the mu delta receptor, but it will become antagonist to the what is that? Antagonist to your mu receptor. So it is having action on both all opioid receptor, for example, but one place it is a antagonist, one place it is a agonist. So these type of drugs are only called as mixed drugs. Mixed drugs. So these mixed drugs, we have drugs such as, very good. What is that? We have something called as nafazolin. What is that? Nafazolin. Okay. Apart from nafazolin, we have one more drug that is only called as pentazokine. What is that? Pentazokine. And we have one more drug that is called as buprenorphine. What is that? Buprenorphine. So all these drugs, nafazolin, pentazokine, and buprenorphine, that is your mixed agonist and antagonist drugs. Okay. Now, for example, guys, when you understand about mixed agonist and antagonist, they're used usually for the pain management and addiction management. If the person is addicted for the opioid, during addiction treatment, we can use them especially to manage the pain. So these drugs will cause no addiction, but suppress the pain. This is the advantage of your mixed agonist and antagonist. Then let's go to the next one. They're only called as opioid antagonist. Antagonist means what, my dear students? Opioid antagonist block the opioid receptor. Please understand, opioid receptors are blocked by the opioid antagonist, because this question asked numerous times and many people make very small mistakes, silly mistakes. So please don't do it. Okay. Now, what do we have? We have a drug called as, my dear students, that is called as naloxone. What is that? Naloxone. Okay, naloxone. Okay, naloxone. Then we have one more drug that is only called as naltrexone. Naloxone and naltrexone. So what is this naloxone and naltrexone? These two drugs, my dear students, this naloxone is a short acting drug. Is a short acting. If it is short acting, any short acting drug will be short acting, will be always fast acting. Short acting drugs will be always fast acting. So it is a short acting and fast acting. And my dear students, this will become the antidote. This is the antidote for opioid overdose, for the opioid overdose. So please remember, opioid overdose, the first antidote, IV antidote will be naloxone. Okay, now please understand, naltrexone is available in the form of a tablet form. Naltrexone is available in the tablet form. It is available in the tablet form. So this drug can be used for the long-term management of the opioid addiction. So for the opioid addiction, we use this drug, that is your naltrexone. So please understand other important factors, important facts about opioids. Facts about the opioids. My dear students, most of the opioids, you need to understand. They need to understand these opioids can cause respiratory suppression. All of us know that. If they're causing respiratory suppression, that can cause the death. That can cause the death of the patient. So please understand. These opioids prolong, one important thing to be remembered, prolong second stage of labor. Prolong the second stage of labor. So if at all you are using opioids in the painless delivery, see this modern era, there is a excessive quantity of painless normal vaginal delivery where we use opioids. During opioid usage, it might prolong the second stage of labor. Okay, sir. Then all opioids can lead to addiction. Opioids can lead to addiction, of course, sir. Is there anything else? Yes, these opioids will cause severe sedation, and they will also decrease the sympathetic outflow. They will decrease the sympathetic outflow, means they suppress the sympathetic activity. If they are suppressing the sympathetic activity, means they're contraindicated in the patient with the bronchial asthma. So you shall not supposed to use the opioids. You are not supposed to use the opioids. So opioids are contraindicated. In the patient who is having what is that? That is your bronchial asthma. So this is a story of your that is your opioids. This is a story of your opioids. So once you are done with the opioids, I'll give a quick summary. All the opioids are used for the management of pain only. That is a major usage. The effects are PMA. So there are three classifications: opioid agonist, antagonist, then antagonist, then we have the antidote, then we are talking about facts about the opioids. Okay, now the opioid, if person has a opioid overdose, what is that? Opioid overdose. What are the clinical features he is going to get? Opioid overdose patient will come to you with a decrease of respiratory rate. Okay, why respiratory rate? Because of respiratory suppression. Doctor, is there anything you can see in the eye of the patient? Is there anything which you can see from the eye of the patient? From the eye of the patient, of course, it will cause mydriasis or meiosis. It will cause meiosis. So meiosis will happen. Pupil become so small, that is only called as, my dear students, pinpoint pupil. It can lead to pinpoint pupil, or you can remember it as meiosis. Okay, meiosis. And patient will also can have, in a large doses, there can be decrease of heart rate also can occur. Okay, decrease of heart rate, and of course patient overdose means a patient will be unconscious. Usually Unconscious. Okay. So when you get this patient, what is the best drug you can give? IV naloxone. What is that? IV naloxone. So IV naloxone can be the best drug to give in a patient with a opioid overdose. Clear, everybody? Clear? Okay. Now, once you understood about opioid overdose, let's go to the next important thing, next important group of drugs. What is that next important group of drugs? That next important group of drugs, I want to start with the antipsychotics. So before going into the antipsychotics, let's start with one basic idea. So what is that basic idea? We finished opioids here. Okay, we are starting with one of the most important thing, my dear students, in the psychiatry, what are the symptoms we are going to get? All the symptoms in the psychiatry, all the symptoms can be divided into positive symptoms, okay, and one more type of symptoms, they are only called as negative symptoms. So what are the positive symptoms? Positive symptoms such as positive symptom. What do you have, doctor? The positive symptom what you have here, the positive symptoms such as hallucination, okay. Apart from hallucination, is there anything else? Yes, there are other things such as illusions, okay. These are hallucination, illusion, okay. All these irritation, psychosis, psychomotor agitation, all these are coming under a positive symptom. Negative symptom means patient will have loss of interest, okay. For example, we have anhedonia, okay. Then we have apathy, all these type of symptoms. So basically, if there is a loss of interest in their life or anything, loss of interest type of symptoms, we call them as negative symptom. Okay, if there is a positive symptom like hallucination, like delusion, like illusion, okay, all these things will come under your positive symptom. Sir, what about the next thing we need to understand? What is this psychosis and neurosis, sir? So understand, we have something called as psychosis, we have something called as neurosis. By both of them are psychiatrically stable or unstable? Both of them are unstable. But the thing is that some people will tell psychosis means extreme madness, okay, and neurosis means less madness. No, not like that. Rather than that, you need to understand. So first thing, psychomotor agitation. Patient will be irritable, psychomotor agitation. He'll be shouting, he'll be doing all these things like, he won't listen to anybody. Agitation is present in neurosis also and psychosis also. But psychosis, it is a extreme level. Okay. And here we differ patient who is a psychotic patient and neurotic patient. Patient is aware means what? He knows about his symptom. If you tell the neurosis patient, tell him that, bro, listen, you are having psychiatric disturbance, go and see a doctor. Will he listen to you or he'll beat you? So listen to me. He will be aware and he will listen to what you say. He'll say, okay, yeah, I do have the problem. The patient will accept it, that he has a problem. That type of things will put them under neurosis patient. If that is not there, you go and tell him, भाई पागल हो गया, तुम्हें चाकू मार के मार डालेगा वो, ऐसा लोग. So he'll come and you go and tell, dude, you have gone mad, go to psychiatrist. He'll come with a knife. யாவன்டா சொன்னது? யார் சொன்னது உனக்கு? Like, who told you that? So that kind of psychomotor agitation will come in a patient with a psychotic patient. Okay. Now guys, understand. So psychotic patient, we need to treat the patient. So how can we treat the patient? So that treatment with the help of our antipsychotics. What is that? Antipsychotics. What is that? Antipsychotics. My dear students, antipsychotics are divided into two types. Antipsychotics. Excuse me. I'm sorry, guys. Antipsychotics. So antipsychotics are divided into, my dear students, called as typical antipsychotics. What is that? Typical antipsychotics. What are these typical antipsychotics? Even before going there, all these antipsychotics, see, we have a theory saying that dopamine is the evil of everything. So that means dopamine, see, there is a theory that dopamine is the cause of psychosis. So psychiatric symptoms are majoritarily caused by dopamine. They have a theory. So what they are going to do is they are going to inhibit all the neurotransmission. So that is how we are going to use the antipsychotics. Basically, they inhibit dopamine receptor, but the psychiatric drugs have been developed from so olden times. They will have so many problems which we are going to learn. Okay, so when we need to understand these typical antipsychotics, my dear students, they are the old drugs. Okay, now old drugs, they are not specific, not receptor specific. If they are not receptor specific, what do I mean by they are not receptor specific? Because, my dear student, dopamine receptors are such a type of receptors. They are supposed to be blocked in a psychotic patient, but a typical antipsychotics will go inside the brain. They are not specific only to the dopamine receptor, but rather they will block other receptors such as alpha receptors in the brain. It will block histamine receptors in the brain. It will block YAM receptors in the brain. So it is blocking all the other receptors. So that is what is the problem which is associated with the typical antipsychotics. Okay, now typical antipsychotics, the drugs, we have drugs such as chlorpromazine. What is that? Chlorpromazine. Okay, apart from chlorpromazine, we have a drug called as haloperidol. Okay, apart from haloperidol, can anybody tell me any other drugs? We have one more drug, my dear students, that is your droperidol. Okay, then we have one more drug called as flufenazine. What is that? Flufenazine. Okay, we have any other drug? Yes, we have one more drug. That is only called as thioridazine. What is that? Thioridazine. So all these drugs are the old drugs. They are your chlorpromazine, haloperidol, droperidol, but only problem with them, they will block other receptors also, that is alpha, histamine, and also YAM receptor, which is good thing or bad thing? It will become a very bad thing. So my dear students, please understand, chlorpromazine causes one side effect. It will cause something called as a cholestatic jaundice. What is that? Cholestatic jaundice means it will decrease the movement of the bile. This is one weirdest side effect which we can get as a result of your, what is that? That is your cholestatic jaundice as a result of chlorpromazine. Okay, so because of this alpha blocking, because of this M blocking, because of this H blocking, there are so many antipsychotic drugs which we don't use them as antipsychotics anymore because of this non-specific blockading property, my dear students. Okay, now when you look at these things, so what happened was we developed a newer drugs. They're called as atypical antipsychotics. These are the newer drugs. And my dear students, they will block dopamine receptor, okay, and serotonin. That's it. 5-HT receptor. They'll block only two types of receptor, dopamine receptor and 5-HT receptor. So these drugs becomes newer and a very better selective drugs. These atypical drugs, we have drugs such as QTapine. Okay, apart from QTapine, we have a drug called as olanzapine. What is that? Olanzapine. Okay, apart from olanzapine, we have a drug called as clozapine. What is that? Clozapine. We have a drug called as clozapine. Okay, we have one more drug called as ziprasidone. What is that? Ziprasidone. What is that? Ziprasidone. Okay, so all these drugs are your newer antipsychotic drugs. What is that? Newer antipsychotic drugs. We have even more drugs such as apiprazole. What is that? Apiprazole. Apiprazole. Okay, so apiprazole, but it is not apiprazole, but it is not a pantoprazole or PPI. So you need to remember apiprazole is a antipsychotic drug. Okay, then we have one more drug such as risperidone. We have a drug called as risperidone. What is that? Risperidone. So risperidone is a very important drug. What is that? Very important drug because it's very widely used drug and which is shown to be safer in the younger females. Okay. Now, my dear students, what exactly we need to understand? These drugs are having some importance here. Olanzapine is such a drug which is good for pregnancy or bad for pregnancy. It is safe in the pregnancy. It is safe in the pregnancy. Guys, 1 second. So, olanzapine is such a drug. It is safe in pregnancy. It is safe in pregnancy. So, if pregnant female comes to you with the complaints of psychosis, then you can use which drug, my dear student? That is only your olanzapine. Apart from that, for example, you had a patient of schizophrenia. You gave him the treatment of schizophrenia. After you give him the treatment of schizophrenia, the drugs were not responsive. Means you used all other drugs, still patient symptoms are not going. Then you can go for one drug. What is that? That is your, my dear students, this clozapine is a drug of choice for resistant schizophrenia. For the resistant schizophrenia, what is that? Resistant schizophrenia, and this drug will also cause one more problem. Can anybody tell me that one more problem? This will cause one dangerous problem. Anybody? Clozapine will cause one of the dangerous problem. The dangerous problem is seizure. Okay. So listen to me. Clozapine can cause one dangerous side effect. That is very good. That is your agranulocytosis. That is your agranulocytosis. Okay, this agranulocytosis is a very dangerous side effect, and along with that, understand this agranulocytosis is not only side effect, it will also cause one more side effect that is called as wet pillow syndrome. Sir, what is wet pillow syndrome? Wet pillow syndrome, what happens is that because of the 5-HT receptor blockade, person when he is sleeping, the salivation will be so high that all the pillow will become wet of his saliva. Okay. Now, my dear students, this clozapine is one more thing. In a patient with schizophrenia, it decreases the suicidal tendency. What is that? It decreases the suicidal tendency. It decreases the suicidal tendency. So these are the effects which you need to remember about clozapine. So please understand, there is one last side effect, quetiapine causes one side effect, that is your cataract, my dear students. What is that? Cataract. So far whatever I taught to you people might be little overwhelming information, because you'll have to remember a lot which is safe, which is not safe, because of this drug nature itself. They're like that, we cannot do anything. Okay. Now, I want you to understand extrapyramidal effects achieved as a result of, my dear students, that is antipsychotics. What they will do, see, all the antipsychotics, they will block dopamine receptor. If dopamine receptors are blocked, that means dopamine receptor activity is decreased. In which location? In substantia nigra also. Yes or no? In the substantia nigra also. One substantia nigra patient has a dopamine receptor suppression. Now the patient will develop something called as a drug-induced drug-induced Parkinsonism. Yes, drug-induced Parkinsonism can occur as a result of your substantia nigra suppression. The patient will develop something called as extrapyramidal symptoms. What is that? Extrapyramidal symptoms. What are these extrapyramidal symptoms? In the Parkinson disease, I taught you people. Parkinson, what happens? Dopamine activity is reduced. Here are drugs are reducing the dopamine activity. So patient is going to get extrapyramidal symptoms. So in the extrapyramidal symptoms, again, please understand one of the most interesting symptoms such as akathisia. Symptoms such as akathisia, and patient will also get tardive dyskinesia. What is that? Tardive dyskinesia. These are the two clinical feature you need to remember as a result of drug-induced Parkinsonism. Then later patient will develop dystonia, tremors, agreed, dystonia, tremors, and all those things you will develop later. But starts most important are akathisia, tardive dyskinesia. Among these three clinical feature, the first clinical feature will be the first clinical feature. If they ask you people, what is the first clinical feature? Dystonia. Then your second usually akathisia. This much depth they won't ask. Third usually your what is that? Third usually will be your tardive dyskinesia. After that, perioral tremors around the mouth tremors will come. That will be the last clinical feature, which is starting as a result of your dopamine receptor blockade in the substantia nigra as a result of your usage of the drugs. Which drugs? Antipsychotic drugs. Everybody clear so far? Everybody clear so far? Now, once you understood about this, please tell me if you understood or not. Yeah, today actually CNS will become so many drugs. Now that will be a little bit difficult. It's okay. Got it? So far, antipsychotics clear, anti-Parkinson clear, opioids clear. Okay, awesome. Let's continue. So when we need to understand about this, when we need to understand about the next group of drugs, very nice. Next group of drugs, now listen to me very carefully there. Very interesting ones. They are your, my dear students, mood stabilizers. What is that? Mood stabilizers. What is that? Mood stabilizers. Sir, what are these mood stabilizers? Mood stabilizers are very easy for you to understand. Mood stabilizers are used in the management of a disorder called as bipolar disorder. So bipolar disorder, I'll teach you people how to remember. Listen to me. It is a combination of mania and depression. If I tell you like this, nothing you'll remember. Okay, how this person will be for 3 months, he'll be like, yeah, I'll do that, I'll do this. So for everything he'll get excited, he'll go fight with everybody, he'll argue, hey, why did you say that, man? Why did you do that? Full excited. Okay, yeah, I will do that, I'll do this. He'll go meet with accident also, he'll become full all mad fellow. Now, after 3 months, slowly he'll become so silent that barely you can notice he's existing. He won't come out of his room. He's quiet, he's silent. So there is a anand of mania and depression. Anand of mania and depression together. We call it as a bipolar disorder. See, but pole means what? Extremes. Now, pole means extreme end. Bipolar means either mania extreme end will be there, or it will be end of depressed extreme end. That is why we call it as a bipolar disorder. So for bipolar disorder, we use lithium. My dear students. What is that? Lithium. So what is this lithium? Lithium is available in the form of lithium carbonate. It is available in the form of lithium carbonate and also in the form of lithium citrate. Okay. Now, my dear students, these mood stabilizer, after giving up, so he'll come with mania, immediately he'll give mood stabilizer and patient will become mood will be stabilized or what? No, these drugs are the first thing. Let's start with here, the nature of the drugs. These are the heavy metal drugs. heavy metal drugs. These are the heavy metal drugs. When given, after giving, they will be slow onset. So slow onset is there means slow onset is there. If slow onset is there, just you can give lithium and you can wait. See, he's going all crazy, madly he's behaving. For that mad fellow, you'll give lithium and you'll just let him go like that. No, slow onset. So till then, so it should be always combined. It should be always combined with antipsychotics, which is that combined with the antipsychotics, combined with antipsychotics. And please understand these heavy metals. Because of this heavy metal, they will cause nephrogenic diabetes insipidus. This nephrogenic diabetes insipidus is a dangerous thing. So my dear students, nephrogenic diabetes induced by lithium, the drug of choice during this time, the treatment will be amyloid. Amyloid is what? Amyloid is your potassium sparing diuretic, but how exactly it works we don't know, but it does work in the treatment. So amyloid, if it is not there, then you can go for triamterene. The drug belongs to the same group. And my dear student, it will cause ECG changes. Lithium will cause ECG changes. What type of ECG changes? Please understand. T-wave elevation, that is your T-wave elevation. I taught you people already seen with T-wave elevation used to be seen with which disorder? It used to be seen with your hyperkalemia, but here also T-wave elevation will be there. Apart from that, it will affect your endocrine system. It will affect your endocrine system, leading to hypo or hyperthyroidism. Majority what we can find is a hypothyroidism. Along with that, patient can develop tremors. So this is the side effects which are caused by the lithium. So it is most important to be remembered. This drug can cause nephrogenic diabetes insipidus, which is very dangerous. So to prevent this side effect, we need to do something called as TDM. Yesterday I taught you people what is the TDM? Therapeutic drug monitoring. What is that? Therapeutic drug monitoring. What you are going to do? You are going to check for the levels of the lithium in the blood. So you are going to monitor. Li means lithium. Okay, lithium levels of the blood. If you're monitoring the lithium levels of the blood, my dear students, please understand. We have some level 0.8 to 1.2 milliequivalents per liter. This is the therapeutic range or a treatment range. This is the therapeutic or a treatment range. If it is more than 2, milliequivalent per liter, this is a dangerous level. Are also called as toxic range and life threatening. If more than 3 milliequivalents per liter in the blood, that means life threatening. Okay, so if you can't remember this many values, remember this much: 0.8 to 1.2 is the level accepted for the treatment in the bipolar disorder. So in the blood, 0.8 to 1.2 milliequivalents per liter lithium should be there to achieve the therapeutic effect. This is a story of your lithium. So once we are done with the lithium, we are left out with antidepressants, anti-epileptics, and your anxiety medication and CNS will be done. Okay, everybody understood so far? If you understood so far, we will take a small break, then we will continue. Is that okay? Or shall I just jot down every drug here is existing and just go further? So shall we take a break? Okay. All right. So we'll take a break of how long? So it is 1821 means this is 621, right? So take a break till this break. Let's make it bigger break. Break till 6:45. 25 minutes. Take a break. Have your snacks. Get freshen up. Okay. और फिर आते, ठीक है? आप अपना अपना एनर्जी लेके आओ जाओ. Everybody, whoever wants their energy, get it. Bye bye. Till 6:45. Everyone back? Shall we start? So please drop a message in the group asking everyone to join. Ask everyone to join quickly. Quickly, please. Can you see me? Can you hear me? All right. So far we studied about one of the most important aspect, that is your, what is that? That was your drugs which were acting upon the treatment of your, what was that? Treatment of your mood stabilizer, that is bipolar disorder, that was your lithium. Okay. Now you understood about the lithium, you understood about all other drugs. Yes or no? So now, my dear students, let's start with understanding of the next group of drugs. They are your one of the very widely used drugs, Okay. So these widely used drugs, what are those widely used drugs? They are your anxiety medications. Okay, so let's start with the anxiolytics. Anxiolytics and hypnotics. Anxiolytics and hypnotics. Okay, so basically these medications are used for the treatment of anxiety. So what are the uses of this medication? Where do we use? This is the first thing. So where do we use it? The main purpose of anxiolytic medication is to treat the anxiety. Okay, anxiety management. Okay, apart from anxiety, one more place where patient is not able to sleep, so if he is not able to sleep, we are going to use the same anxiolytic medications, that is your in the treatment of insomnia. Can anybody tell me definition of insomnia? What is insomnia? Please tell me. What is insomnia? Inability to sleep is insomnia or what? So this is not a complete definition of insomnia. Now listen to me very carefully. I have a patient who went to the bed. He went to bed at 10 p.m. Okay. From 10 p.m. but actual sleep started at 12 p.m. Okay. So from the time of going to bed and getting the sleep, if this duration is prolonged, we call it as insomnia. If it is prolonged, we call it as insomnia. So what is insomnia? From the time of going to the bed, till patient is sleep. Okay, so that is only your anxiolytic and hypnotic drugs. Okay, now anxiolytic and hypnotic drugs are used for the treatment of your, that is your this thing. What is that? Insomnia. Now, my dear students, understand, in our central nervous system, you have a excitatory nervous system. Excitatory, what is that? Excitatory neurotransmitter is glutamate. That is glutamate. Okay, excitatory neurotransmitter is glutamate. And we have one more type of neurotransmitter, that is your inhibitory neurotransmitter. What is that? Inhibitory neurotransmitter. This inhibitory neurotransmitter, my dear students, is your, what is that? GABA. That is your GABA. Okay. Now understand. For example, I have a nerve. Okay. Now this nerve is connected to the one more nerve. This nerve was connected to one more nerve. And again here there was one more nerve. There are totally three nerves together. We call it again as a synapse only. So two nerves, three nerves, both of them are communicating together. That means that is your stimulatory, that is your synapse only. Okay. Now what happens? Consider this was an excitatory neuron. Now this excitatory neuron, what it does, it will produce something called as a glutamate. Now this glutamate will be stored inside a vesicle. Okay. Now, my dear students, when glutamate gets released, it will go and stimulate NMDA receptor. It will go and stimulate NMDA receptor and AMPA receptor. You might be thinking, sir, NMDA and AMPA are what? Basically, end summary, because of NMDA and AMPA, there is an increase of sodium and calcium inside a neuron. Basically, these work as a ion channels, but with the help of glutamate. Okay, so glutamate stimulated your NMDA and AMPA. Now, once they stimulated NMDA and AMPA, sodium and calcium increase the cell, the nerve becomes excited. Okay, excited. So nerve becomes excited. But the issue is that if at all you are always excited, that is bad. You'll go and you are trying to sleep at 2 a.m. At 2 a.m. you are full active with full attention. That will become a problem because you cannot get the sleep. So what our body does, it will do a regulatory mechanism. Okay, how it will do the regulation? With the help of a neuron called as, that is inhibitory neuron, that is your GABA. So there is something called as GABA. Now, my dear student, whatever GABA is there, now this GABA will be released. Okay. Now GABA will come and stimulate some receptor called as GABA receptor. What is it? GABA receptor. Again, GABA receptors are divided into GABA A, GABA B. That is not required for you people. But once these GABA receptors are stimulated, now this GABA receptor will allow the entry of chloride ions. So chloride ions means cell will become more negative. If cell is becoming more negative, means cell is going into a state called as a hyperpolarized state. If cell becomes hyperpolarized, automatically what is going to happen? The person will go into the rest mode. Because nerves are not excited anymore. So basically, GABA and NMDA, all of them are working together. Okay. Now, listen to me very carefully. You have this GABA, right? Now, GABA when it is released, my dear student, this GABA can be reuptaken. Reuptake of the GABA can be done by the help of GABA transporter. GABA transporter. So GABA transporter is there. This GABA transporter, this transporter will help in the reuptake. Reuptake means GABA will come back to the nerve, and in the nerve GABA will remain. Now GABA, whatever is reuptaken, this GABA can be reutilized again. But one more thing, this GABA is metabolized into its degradation products by an enzyme called as GABA transaminase. So far what I have told you people, listen to me. There is a neurotransmitter called GABA that will be released, go and stimulate the GABA receptor, leading to the entry of chloride ions. Okay, sir, clear. Now, chloride ion entry causes hyperpolarized state, so cell will go into rest. Got it, sir. No problem. Now, this GABA, sir, GABA can be reuptaken by GABA transporter. Now, GABA can be reutilized. At the same time, it can be metabolized by an enzyme called as GABA transaminase. This is the life cycle of your gamma aminobutyric acid, that is your GABA. Now, when you need to understand about that, we have some anxiolytic medication. These anxiolytic medications are very important ones. Why? Because, listen to me, we have some drug called as benzodiazepines. What is that? Benzodiazepines. BZD means benzodiazepines. Okay. benzodiazepines. My dear students, these benzodiazepines will go and bind with GABA receptor. Which GABA receptor? Specifically speaking, GABA A receptor. Okay, they will go and bind with the GABA A receptor, and what it is going to do? It will go and bind with the receptor. It will not stimulate the receptor. Listen to me. It will not stimulate the receptor, rather it increase the frequency of opening again and again. He will open the GABA channels. That's it. Okay, he will increase. See, increase means there are two possibilities. Open the GABA channel and hold it like that only. Chloride will enter. Possibility number one. One more possibility. Open again, close, open, close, open, close. But frequency of opening has been increased. If you increase the frequency of opening, then chloride entry will also be more. Increase the frequency of opening. Increase the frequency of opening. Basically, you had your this. Consider this is your neuron. Here you had a GABA receptor. Now benzodiazepine comes and binds. Once it binds, he will allow opening again and again. So every time opens, chloride ion will come. So increase the frequency of opening, increase the chloride ion concentration. So automatically this is the mechanism of action of your benzodiazepines, my dear students. Okay. Now, sir, if you are telling about benzodiazepines, they are increasing the frequency of opening. So what are the drugs we have? Drugs, what do we have, are very interesting ones. The drugs we have are that is your diazepam. What is that? Diazepam. Okay. Apart from diazepam, is there anything else? Yes, lorazepam. Okay. Is there anything else? Yes, we have one more drug, that is midazolam. What is that? Midazolam. Okay. Apart from midazolam, is there anything else? Yes, they are there. That is nitrazepam. That is nitrazepam. So all the zapams and zolams are your benzodiazepines. Okay. Now, when you're talking about a benzodiazepine, my dear doctor, these are very interesting ones, very interesting drugs. Okay. Now, even we have one more drug, okay, that is your clonazepam. Okay, clonazepam. Okay, apart from clonazepam, we have one more zolam, that is alprazolam. Okay, so all these zolam and zapams are your benzodiazepines. So benzodiazepines, my dear students, uses of the benzodiazepine is very interesting one. What is this very interesting one? They're used for anxiety, agreed. Used for anxiety, of course. Used for insomnia, agreed. Okay. Apart from that, is there anything else? Anxiety, insomnia. Apart from that, they're used in the seizures. If patient is getting an active seizure in antiepileptics, I'll tell you people about which drug when to use and all. But for now, remember seizure. Okay. Now you have one thing, that is your diazepam. Diazepam is a special drug. What is this? This is myorelaxant also. Okay, myorelaxant also. If you people remember or not, in the chapter of myorelaxant, I taught you people diazepam works as a myorelaxant. Okay. Now, once you understood about this, now look here, benzodiazepines. Okay, you got about the uses. Okay, and you understood about these things. And again, when we are going into the next aspect, my dear students, benzodiazepine, if there is an overdose, then what is going to happen? If there is an overdose, antidote should be given. The antidote for benzodiazepine overdose is flumazenil. What is that? Flumazenil. Antidote for overdose of benzodiazepines is flumazenil. This question can be asked. Okay, this question can be asked. So this is a story of your benzodiazepines. Okay, now benzodiazepines, sir, this much only is there or what? There is so much about benzodiazepines. Now, benzodiazepine uses of myorelaxant, go to myorelaxant chapter. Epilepsy part will go to epilepsy chapter. Like that, other places also will get these things again and again. Okay, now we have next group of drugs. Next group of drugs are called as Barbiturates. What is that? Barbiturates. My dear students, understand barbiturates. These are the derivatives of, means they're made out of derivatives of barbituric acid. What is that? Barbituric acid. What is that? Barbituric acid. If they are derivative of barbituric acid, means they are acidic drugs or alkaline drugs. They are acidic drugs. You need to remember this. Acidic drugs. Okay. Now, sir, what about these drugs? These drugs are very interesting ones, sir. What they do is that, see, one was doing for again and again. Now, this guy, what he will do? He will do it for a longer period of time. What is that doing? That is opening. Okay. So, exactly barbiturates, mechanism of action is they increase the duration of opening. They increase the duration of opening. They increase the duration of opening of the GABA receptor, or duration of opening of the GABA receptor. So duration of opening of the GABA receptor will be increased. More chloride ion. More chloride ion means more of your hyperpolarization. Person will go into the rest. Okay. Now. Guys, please listen to me very carefully. When you're learning about barbiturates, we have barbiturates. So we have drugs. That is phenobarbital. What is that? Phenobarbital. Okay. Apart from that, phenobarbital also we can say, phenobarbital also we can say. Both of them are right only. Okay. We have drugs such as secobarbital. Okay. Secobarbital. Okay. Apart from that, we have one more drug that is called as thiopental. What is that? Thiopental also belong to, what is that? That it belong to barbiturates only. So when you're learning about barbiturates, these barbiturates have a high addiction tendency. They act more like a addiction. They act more like alcohol. So they have a high addiction tendency. So do we use them in insomnia? Not used in insomnia. So not used for insomnia. Okay, not used for insomnia. Okay, sir. Apart from that, these barbiturates, especially your thiopental, used as an induction agent. Means whenever you're doing a surgery, you'll give anesthesia. When you're giving an anesthesia, the first initial phase of anesthesia, the first stage is called as induction, means initiation of the anesthesia. That initiation of the anesthesia will be done with the help of thiopental. But thiopental, again, we have better drugs than that. Again, thiopental is not used. Induction of the anesthesia. Okay. Now, this thiopental also used as a truth serum. It is used as a truth serum. Truth serum contains of two substances, majority one of them was scopolamine, another one is your phenol, that is thiopental. They both combined together given, that is only induction and truth serum, that is used for the narco analysis in a forensic psychiatry. Okay. Now, once we understood about barbiturates, my dear students, when we are learning about barbiturates, so derivatives of barbituric acid, okay, opening frequency, okay, so do we use them? We don't use them. But even though if we use also, they're used for epilepsy patients only. They can be used in epilepsy patients. How we are going to use, we will learn. Okay. Now, my dear students, both your benzodiazepines, when they used, can do one thing, can alter the sleep cycle. Okay. So if they're altering the sleep cycle, means what? We need a better drug which do not alter the sleep cycle, but can treat the insomnia. So sleep cycle. So to overcome this, we developed a new drugs. We use Z drugs. We use something called as Z drugs are used. Now Z drugs will induce the sleep, but no change of sleep cycle. If there is no change of sleep cycle, yes, of course, these can become a superior drugs. So to overcome this, we developed a Z drugs. All of their names starts with a Z, that is zolpidem. We have zolpidem. Okay. Apart from zolpidem, we have one more drug, that is zolpiclone. Okay, so zolpidem, zolpiclone are the Z drugs. Z drugs, all of them. Z drug, the name itself is very clear. They start with the Z. Okay, so what do we mean by sleep cycle? See, sleep cycle, we people need to understand this, young people. So for us, we tend to sleep late in the night, wake up late in the morning. Okay, so our pattern of sleeping will be go to sleep late, wake up late. Okay, but our parents used to have this habit of they will sleep early and wake up early. Okay, now what happens to induce the sleep? To induce the sleep, I give benzodiazepines. When I give benzodiazepines, what can happen is that if at all, if there is a slow onset of action, or if the person is addicted to benzodiazepine, he might get the sleep later. He will get the sleep late, but he will get the sleep. But by the time he get the sleep, and by the time he wakes up, that means the cycle itself is impaired. Why? Because sleeping and waking up time impairment can occur as a result of benzodiazepine. But Z drugs are not like that. You want to go to sleep, so you want to get the sleep right now, so he'll go, okay, 10 minutes before to sleep, he'll take a tablet, within 10 minutes he's out like a light. Okay, so these drugs will not alter the cycle. So sleeping time, waking up time remains the normal, but only thing is that he can overcome the insomnia. That is only sleep cycle. Okay, got it, doctor? Got it? Okay. Now, once we understood about these things, zolpiclone, zolpidem, let's go to the next one. Sir, you said insomnia means increase of the sleep time, but this also does the same. See, not like that. The thing is, consider a person was taking such as, for example, alprazolam. Okay, he is using first 5 days. First 5 days. Now, even low doses, fast onset of the sleep. Fast onset of the sleep. Okay, but the same alprazolam, after regular usage of 1 month, he used it for 1 month. Now what will happen is that the receptors sensitivity will alter and slow onset of sleep. Sleep will come, slow onset. Means what? He'll get better. He'll get better. Okay, but the thing is that the duration of onset will be slower. Okay, first thing. Second thing is that since the onset is slower and some people will have slow metabolism of this particular some drugs. So because of this, what can happen is that the drug will remain in the body for a long time. Morning, he'll not be able to wake up. Night also will get the sleep, but morning he'll not be able to wake up. But these Z drugs are what, they work for short period of time. They induce the sleep and they're out of the body. By the time you wake up in the morning, your body does not know zolpidem existed. Okay, so that type of overcoming can be done with the help of Z drugs. Got it? Okay, so that depends upon the usage, how long and how frequently my patient used it. Okay, so let's continue to the next aspect. What is that next aspect? The next important aspect. So other drugs, other GABA drugs. So other drugs which works with the GABA, other GABAergic drugs, my dear students, they're very easy for you to understand. So what are those? Just think about that. Think about this. If I inhibit GABA transporter over here. If I inhibit GABA transporter over here, this GABA will be available more or less. GABA will be more available because reuptake will be stopped. Reuptake will be stopped. So that is one possibility. You just inhibit GABA transaminase. No metabolism itself. GABA will not break down. Again and again, GABA can release. No new GABA formation is required. So GABA will be more and the person can get to the sleep and you can even achieve the anti-epileptic property. These are the other drugs. So we will come to those. Those drugs are GABA transaminase inhibitor. What is that? GABA transaminase inhibitor. Transaminase inhibitor. We have a drug called as vigabatrin. What is that? Vigabatrin. What is that? Vigabatrin. Okay, vigabatrin. Okay, so if you look here, you can look at the name TR for transaminase, IN for inhibitor. TR for transaminase, IN for inhibitor. So GABA transaminase inhibitor, we have something called as that is vigabatrin. Again, these drugs are used for epilepsy only. Okay. Then apart from that, we can also use a GABA transaminase inhibitor. GABA transaminase inhibitor. When I'm talking to you people about GABA transaminase inhibitor, that drug name, sorry, GABA transaminase, no. I'm writing the same. So we are inhibiting GABA transporter. What is that? GABA transporter inhibitor. So we will inhibit the GABA transporter that is only called as T-gabine. The name of the drug is T-gabine. Okay. Both of these drugs are used for epilepsy management. Used for epilepsy management. Okay. Is there anything else? My dear students, these other drugs we have, they increase how amanitin increase the availability of GABA. Like that, increase the GABA availability. That drugs we have most important drugs, that is your gabapentin. Okay. Apart from gabapentin, we have one more drug called as pregabalin. Okay. Now, gabapentin and pregabalin, they have one special property. What is this? These are, my dear students, neuroprotective. Means they protect the nerves. Since they're neuroprotective, definitely understand gabapentin and pregabalin are used for neuropathy management. Patients like diabetic neuropathy, what are you going to use? Gabapentin or pregabalin. So we are going to use it for neuropathy management. We are going to use them for the neuropathy management. So once you understood about this, please understand these anxiolytics and hypnotics. These drugs, both of them, tigabayine, like both benzodiazepine, barbiturates, and all these things, understand they're not just used for anxiety, but they're widely used in the management of seizures also. So with this much being said, let's go to the next important concept. That next important concept is your anti-epileptic drugs. Post-herpetic neuralgia, diabetic neuropathy, drug-induced neuropathy, in all these conditions you can use. Okay. Even severe pain management also we can use these drugs. Anti-epileptics. When I'm talking about anti-epileptics, yeah, we can use them in seizure, but the thing is that, see, they are basically originally developed for seizure only. We'll talk about it now. They're basically originally developed for seizure only. But the most important thing is that, yes, they are developed for seizure, but rather than seizure, they have better mechanism of action for the neuropathy. So we, we change the drug usage into particular different domain. That's it. Okay. Okay. Let's go to epilepsy. Now, what is epilepsy? What is epilepsy? Can anybody tell me? What is epilepsy? So you have two things now. One of them is epilepsy. Another one is seizure. Sir, epilepsy क्या होता है? Seizure क्या होता है? What is epilepsy? What is seizure? So listen to me very carefully. We need to understand seizure. What is that? Seizure. So when you're looking at a seizure, what happens is that abnormal, seizure is nothing but abnormal neuronal discharge. So what do you mean by abnormal neuronal discharge? Very simple. Imagine your brain is working, like, a part of your brain, for example, let's take, for example, frontal lobe. Okay, frontal lobe is excited, is way too much excited, like, all the nerves connected to frontal lobe will become way too much active suddenly. For example, right hemisphere fully, it will become active all of a sudden and it will stimulate all the nerves. So right hemisphere will control the left half of the body, leading to what is that? Left-sided seizure. So the seizure is nothing but excessive stimulation of the nerves. So this can be caused by many things. So causes for the seizure will vary as a wide range. First cause is idiopathic, unknown cause. Then at the pediatrics, fever can cause the seizure, that is only called as febrile seizure. Okay, then people will have brain injury such as stroke can lead to the seizure. Brain trauma can lead to the seizure. Okay, for example, brain infections like encephalitis, meningitis can lead to the seizure. Vitamin deficiencies can lead to the seizure. Severe calcium deficiency can lead to the seizure. So wide range of causes. Okay, but whenever a person comes to you with seizure, you need to analyze all these causes. Does he have stroke? Does he have, for example, like, does he have any vitamin deficiency? Does he have some mineral deficiency? Does he have any abnormal changes? Brain tumors are there? Is there any infection? All of these things you need to rule out before telling the patient as healthy. Okay, so if you don't find anything, still seizures are there, then you call it as a idiopathic seizure. Okay, now, if at all repeated episodes of seizure, repeated episodes of the seizure, then we call it as epilepsy. Very good, someone answered it. Okay, repeated episodes, we call it as epilepsy. Okay, so when you need to understand epilepsy, my dear students, we need to understand one simple rule. If at all epilepsy is there, your nerve is becoming excited, right? What can happen? There is a decrease of the GABA activity. If inhibitory neurotransmitter is less, excitatory will become dominant. If GABA is less, or excitatory activity is more, increased activity of the glutamate can also lead to, both of these conditions can lead to seizure. Simple as that. Seizure is a excitatory neurotransmitter related condition. Either excitatory is more or inhibitory is less. Both of them can lead to epilepsy. Simple as that. So we use the same principle and treat our patient. So what exactly we are going to do, my dear students? Listen to me very carefully. Here. So if nerve is there, one neuron and another neuron, in both of these neuron here, glutamate is the, see, you have glutamate. Now glutamate will get stored inside a synaptic vesicle, On this synaptic vesicle, when I zoom inside, I have some molecule here. The name of the molecule called as SV2A molecule. Now this SV2A molecule will allow the release of the glutamate. So glutamate will come into the neuron, come in between the neuron only when SV2A is working. Okay. Now this glutamate will stimulate NMDA receptor, and one more type of receptor called as AMPA receptor. Okay. Because of this, they will allow entry of the sodium, potassium, and sodium, potassium, calcium ions. AMPA will allow the entry of sodium ion, calcium ions. But do you have to remember that? No. Apart from that, if nerve has to get excited, any nerve has to get excited, you have sodium channels which will allow the entry of the sodium channel. Then nerve can become excited. Okay. So one target is that glutamate can cause the excitation, NMDA can cause the excitation, AMPA can cause the excitation, and also your sodium. Apart from sodium, also entry of your calcium. So you can treat the epilepsy. By blocking the sodium channel. You can treat the epilepsy by blocking SV2A. You can treat the epilepsy by blocking calcium channel. So all of these are the mechanisms with which we can treat the we can treat the epilepsy patients. Okay. So when you're learning about epilepsy, first thing you need to understand about seizure. You need to understand about seizure. So what are the types of seizures we have? What are the types of seizures we have? So the types of seizures is a very important one. What is this? What is this important one? So types of seizure types of the seizure. So types of the seizure is a very important information to be known. Why you should know the types of seizure? Because there are multiple types carrying multiple different mechanisms and different ways to treat the epilepsy. So for example, we classify all the seizure into partial and generalized seizure. Partial seizure means a part of your brain is involved. Generalized seizure means a complete area, complete brain will be involved. So complete body will be affected. What I'm trying to tell you people is that just imagine only frontal lobe is affected. That will be a partial area. If complete brain is involved, that will be a generalized seizure. That will be a generalized seizure. So we can classify all the seizure into something called as partial seizures. Okay, then we have generalized seizure. So generalized seizures are very important, because generalized seizures we have types such as tonic seizures. We have next type of seizure called as tonic, and we have one more called as clonic seizure. Then we can have combination of these two both, that is only called as GTCS, generalized tonic clonic seizure. We have one more seizure called as myoclonic seizures. So partial seizures will have temporal lobe epilepsy. Okay, so we'll have focal epilepsy. All these things will come in a partial. So partial also again we can subdivide it into simple partial. Then we can divide it into complex partial. And also we will have this partial seizure secondarily will become a generalized seizure. All those types are present, but I want you to understand these are the names. Okay, apart from that other seizures are there. Other seizures which cannot be put under either partial or generalized. That type of seizures we have, such as infantile spasms. Apart from infantile spasm, we have one more type of seizure in the children, that is called as febrile seizure. What is that? Febrile seizure. Febrile seizure will occur as a result of fever. Okay. Then apart from that, we have one more type of seizure called as absent seizure. I'll tell you about infantile types also, absent seizure also, everything with the help of our treatment. Okay, now when we want to treat the epilepsy, we can use, my dear students, we can use benzodiazepines, which I already taught to you people. Okay, apart from that, we can use GABA transaminase inhibitor, of course. Okay, apart from that we can also use what is that? What is that? GABA transporter inhibitor, GABA transaminase and transporter inhibitor, GABA transporter inhibitors. Yes, we can consider them. Okay, then apart from that, we can also use pregabalin and gabapentin. Of course, we can use them, but why don't we use them these days? Especially gabapentin and pregabalin, you'll understand in some time. But understand these benzodiazepines are widely used. Okay, we'll come to that. Now, when you want to understand about the other drugs, my dear students, we have some most important thing. What is that? That drugs are very, very, very important. That is SV2A inhibitor. That SV2A inhibitor, my dear student, the name of the drug is levetiracetam. What is the name of the drug? Levetiracetam. What is that? Levetiracetam. Okay. Now, levetiracetam will inhibit SV2A, means no glutamate. No glutamate means no excitation. But levetiracetam is best used best used during the active seizure. Means, see, patient is getting like doing this, okay. During this time, we'll give levetiracetam, or you think that, okay, he has a stroke, he might get seizure, so I will give levetiracetam. Second one is better. Why? Because we can prevent the seizure from occurring. So best used to prevent the seizure, best used to prevent the seizure, best used to prevent the seizure, and also safe in pregnancy, also safe in the pregnancy, my dear students. So this is your SV2A inhibitor, SV2A inhibitor. So is there anything else? Yes, we have other drugs. What are the other drugs we have? The other drugs are calcium channel blockers. So calcium channel blockers, but these calcium channel blockers work predominantly in the central nervous system, not in the periphery, because how we develop these things. See, MD pharma people is interested in structures of the channels. They're interested in enzyme. They're interested in receptor. Three major things for us. Okay, why we love those things? Because these are the most important things we use to isolate and manufacture a drug. Okay, so based on the structural differences, we make different drugs. Okay, so calcium channel blockers. So what are the calcium channel blockers we have? Anybody? Any calcium channel blocker? All of you know these drugs. See, if I'm giving you time, that means you people know the drugs. Okay. So calcium channel blocker, the classic drug we have is ethosuximide. What is that? Ethosuximide. Okay. Okay. Now, even calcium channel blocker property is slightly shown by your gabapentin and pregabalin, which is not so clinically significant. Okay. Now let's go to the next important ones. There you are, my dear students. That is your sodium channel blockers. Sodium channel blockers, we have a lots and lots of drugs. What are those drugs? That is your carbimazole. Okay. Apart from carbimazole, we have phenytoin. Okay. Phenytoin. Apart from phenytoin, is there anything else? Yes, we have something called as lamotrigine. What is that? Lamotrigine. Okay. Is there anything else? Yes, we do have sodium valproate. Is there anything more? Yes, we do have more. We have more. That is oxcarbazepine. What is that? Oxcarbazepine. Okay, so please understand carbimazole. Okay, sorry, not carbimazole. I'm sorry, carbamazepine. Not carbimazole, carbimazepine. Carbimazole comes under TPO inhibitor. Okay, carbimazepine, phenytoin, lamotrigine, sodium valproate, oxcarbazepine. These are the drugs which inhibit the sodium channels. So, if I have told you about all these things, my dear students, there are some very important conditions. We have some condition here, topiramate. All other drugs, most of the drugs, topiramate. Okay, most of the drugs belong to this group only. Now, when you are learning about these things, listen, focus here. So what exactly you need to understand is that, guys, they will ask you which type of drug used for which type of condition. So drug of choice for which condition, which drug we use. Okay. So they are very important questions. Let's understand those. Okay. So if at all I ever asked you people, what is that? Drug of choice. So which drug is best for which condition? Okay. Let's start with that. If a person is having generalized tonic-clonic seizure, okay, best drugs can be used is sodium valproate. What is that? Sodium valproate. In a patient with a generalized tonic-clonic seizure, we use sodium valproate. Apart from that, other drugs such as lamotrigine can be used. But first drug you need to mark it as your sodium valproate. This is one table which you need to remember and by heart it. Okay, this is very important. Okay, apart from generalized tonic-clonic seizure, then we have, for example, absent seizure. What is this absent seizure? Guys, absent seizure is seen only in kids. seen in the kids. What happens in the kids is that he'll be sitting like this in his classroom. Eyes will be open, but he will zone out. Means what teacher is telling, what's happening around him, he won't fall down, nothing. He'll just be like this, blank. Again, after a few seconds, he'll come back to normal. Again, he'll be like this. So this happens again and again, again and again, again and again. So now what happens? Absent seizure, if baby comes, you look at the age. If the age of the baby less than 2 years, less than 2 years, or if it is more than 2 years. If the age of the baby is more than 2 years, again give sodium valproate. Again give sodium valproate. Okay. Now, if less than 2 years, you use a calcium channel blocker, that is ethosuximide. Okay. So please understand ethosuximide. For example, if somebody comes to you with a myoclonic seizure, again you are going to use which drug? Valproate only. You are going to use which drug? Valproate. You are going to use valproate. Okay. If a partial seizure is there, if you notice something here, if you don't know answer for the drug of choice of epilepsy, then blindly you can partial seizure. Again, we are going to use valproate. If you don't know any answer, what is the best answer? Valproate, sodium, valproate, sodium, valproate will be your best answer. Okay. Now, guys, when we are talking about these things, I wanted you to understand about one of the most important things. Yes. Valproate, if it is not there, then go for carbamazepine. See, first option always valproate, then you go for carbamazepine or lamotrigine. That is not a problem. But always first line drug is a MCQ for you. Okay. So listen to me very carefully, guys. I wanted you to tell you people about phenytoin. Why phenytoin is very important? Because so many side effects, so many facts. So all these things will become MCQs for you people. Okay. So phenytoin is a derivative of hydantoin derivative. Hydantoin derivatives. Hydantoin derivatives. So means they are derived of a chemical called as hydantoin chemical. They are named as hydantoin chemicals. Okay. Now phenytoin is contraindicated in pregnancy. Why? Because it will cause fetal hydantoin syndrome. What is that? Fetal hydantoin syndrome. What is it? Fetal hydantoin syndrome. Basically, baby will develop developmental defects such as cleft lip, cleft palate, and all these things can occur. So we need to avoid the phenytoin in the pregnancy. Okay. Now, apart from that, phenytoin can cause gingival hyperplasia. Hyperplasia because of its effect on an enzyme called as collagenase. Okay, especially collagenase inhibition. Because of this collagenase inhibition, patient will develop a gum hyperplasia. Okay. Apart from that, person can develop a megaloblastic anemia. Patient can develop megaloblastic anemia. All these are side effects caused as a result of one of the dangerous drugs, that is your phenytoin. We need to be very, very careful when you are using phenytoin. Okay. Now, apart from that, it can also cause osteomalacia. Means it can damage the bones. It can also lead to osteomalacia. Okay. So this is the story of your phenytoin. Now there is one more drug, that is your sodium valproate. See guys, these 2-3 drugs are there. You are going to hate them. Sodium valproate. When I'm talking about sodium valproate, this sodium valproate is very interesting one. He will inhibit sodium channel. And also he will inhibit calcium channels. also inhibit a little bit of calcium channels. This is the drug of choice for all the types of epilepsy, but there is some dangerous side effects associated with the sodium valproate also. That is, it will increase the risk of PCOD. It will increase the risk of PCOD. They can ask you people which anti-epileptic drug is contraindicated in PCOD female. Of course, in PCOD female, don't use valproate. You can go for lamotrigine, carbamazepine. Okay, then this can also lead to one side effect, hepatotoxicity. It can also lead to a side effect, hepatotoxicity. Okay, apart from hepatotoxicity, this drug can also lead to neural tube defects in the baby. If you give in the pregnant female, the baby can develop neural tube defect. And one more thing, there is a increased risk of increased weight gain. Patient will gain much weight. So increased weight gain, again, it will increase the risk of PCOD. Okay. So this is a story of your sodium valproate. But my dear students, there is one more problem that is called as status epilepticus. What is that? Status epilepticus. Yes. See, gastritis will be there. Severe gastritis will be there for most of the anti-epileptics. Okay, that is not an important ones for us. Status epilepticus. Status epilepticus means patient will be getting the seizure in front of your eyes for a longer duration of time. Okay, so if patient is having epilepsy in front of your eyes, then we can call it a status epilepticus. There is one more thing. That is, one time he'll get seizure, he'll be unconscious, again he'll get seizure. Means one seizure, second seizure. In between, there is no awakening only. That is also called as status epilepticus only. Okay. So during the status epilepticus, if the patient is getting a seizure in front of your eyes, first drug, you are going to use lorazepam. Okay, textbook says the best drug is lorazepam, is better drug than your midazolam. Okay, sir, but mostly we use midazolam only, because midazolam is widely available compared to lorazepam. That is the reason we use it. Okay, now if at all no response, you gave lorazepam, no use. If there is no use, then you shift the patient to phenobarbital. If at all that time also no response, if at all no use of phenobarbital also, still is getting the seizure, what will you do? See, levetiracetam will prevent the seizure from happening, which is already happening, won't be useful for us. That is the thing. That's why I told you people that many times. No use. If there is no use, then you shift the patient into phenytoin. We have one more drug called as fosphenytoin. Same group of drugs, fosphenytoin. Okay, you can shift to phenytoin. After shifting to phenytoin, see, we are going to oldest and strongest drugs. Okay, that also no use. Then you put the patient under general anesthesia. This is the last treatment we have. Most of the patient will recover in this stage itself. In the first stage itself, if that does not work, by the time they reach the second phenobarbital, they will recover. That won't be a big problem. Okay. So this is a story of your lorazepam and anti-epileptics related. Okay. But my dear students, I want you to understand epilepsy in pregnancy. Epilepsy in pregnancy, if I tell, everyone will tell me blindly, sir, MgSO4. Why MgSO4 is totally different thing. Okay, please understand this. Okay, now for example, just imagine female is having a history of epilepsy. Is there. She was on valproate. Okay. Now she will become pregnant. Now, can you use it? Now she will become pregnant. You cannot use valproate. Because it will cause neural tube defects in the baby. So during pregnancy also we need a drug. No? So earlier we used lamotrigine. Lamotrigine. Okay. Now, apart from lamotrigine, please listen to me. Now, what happened was recent times, very recently, now what drug we have? That is levetiracetam. That is levetiracetam. Levetiracetam. For example, first marker, if at all levetiracetam is in the option, this is the best. If that is not there, this will be the second best. This will be the second best. Okay. So first best drug is levetiracetam. Then if it is not there, then go for the second best drug. That is your lamotrigine. Second best drug, lamotrigine. So these are the drugs which can be used in the pregnant female. For example, if she is having eclampsia, then you are going to use MG. MgSO4. Then you are going to use MgSO4, that is IV. When you are giving MgSO4, what will you monitor? When you are giving MgSO4, what will you monitor? When you are giving MgSO4, what you are going to monitor? You need to monitor. Very good. What is that? Knee-jerk reflex. Very good. Very good. Very good. Knee-jerk reflex should be monitored. If MgSO4 overdose occurs, what is the treatment? I taught you people yesterday. Let's see. Very good. Calcium gluconate. Proud of you guys. Very nice. Very nice. So this finishes your anti-epileptics. Anti-epileptics. We are done with the anti-epileptics. So once we are done with the anti-epileptics, then we are left out with the last topic of the CNS, that is your antidepressants. What is that? Antidepressants. Okay. Shall we start antidepressants? Or do you need some small 5 minutes? Because of epilepsy being too much information. You need 2-3 minutes?
Hard.
Okay, we'll start it. All right. Let's start with the next topic called as antidepressants. What is that? Antidepressants. So when you're talking about antidepressants, guys, antidepressants are very interesting drugs, very widely used drugs. And one of the most important thing you need to understand, that the important thing is that these antidepressants are a very special group of drugs, based on their chemical structure, based on their mechanism. They're totally very, very interesting. Okay. So when we need to understand about the antidepressant, let's start with one of the basic theory. There is a theory that in the brain, we have neurotransmitter. Such as noradrenaline and serotonin. Okay. The theory said that because of reduced norepinephrine and serotonin, patient was developing depression. So we started to focus on that particular area and started to develop the antidepressant. So when we started to develop the antidepressant, look here guys, one neuron is there, another neuron is there. Okay. So what exactly happens here is that, guys, these neurons will release norepinephrine, of course. These neurons can also release what is that? Serotonin. Now, what happens is that this norepinephrine and serotonin will stimulate the nerve, the postsynaptic nerve. That means patient will become active and interested in the life. But is it a completely, absolutely proven theory? No, it is having again drawbacks also for this theory also. Okay. Now, this norepinephrine can be reuptaken. Even serotonin can be reuptaken. All our antidepressants will inhibit this process. Okay. If we inhibit this process, what happens to norepinephrine? Increases. What happens to serotonin? Increases. Exactly my problem was decreased. So I'm treating the depression. So based on their mechanism of action, and based on their chemical structures, they're divided into first group of antidepressant. They're called as tricyclic antidepressants. So when you're talking about tricyclic antidepressants, why did we call them tricyclic? Tri means how much? Three. Tri means how much? Three. Cyclic means what? Ring. So this tricyclic antidepressant contain three rings. Three rings. Chemical structure, they contain three rings. That is why we call them as a tricyclic antidepressant. Each ring will contain how many carbon atoms? 4 carbon atoms. Contain three rings. Each ring is made out of 4 carbon atoms. Okay, that 4 carbon atom is not important. They contain three rings is very important for you people to know. They contain three rings. That is why we call them as a tricyclic antidepressant. Now, tricyclic antidepressants, my dear students, their mechanism of action is that they will inhibit reuptake. They will stop the reuptake of whom? Reuptake of serotonin, that is your 5-HT serotonin, and as well as your norepinephrine. Means tricyclic antidepressants were named as tricyclic based on the chemical structure that they contain three rings. They inhibit the reuptake of both serotonin and norepinephrine. They inhibit the reuptake of serotonin and norepinephrine. So these are your tricyclic antidepressant mechanism. Now, when you look at a tricyclic antidepressant, my dear students, we have drugs such as imipramine. We have drugs such as imipramine. Sorry, imipramine. Okay, imipramine. Now, we have a drug called as imipramine. Imipramine. We have a drug called as amitriptyline. Amitriptyline. We have a drug called as nortriptyline. Okay, amitriptyline, nortriptyline. All these drugs are your tricyclic antidepressants. So amitriptyline, nortriptyline, imipramine, all these drugs are your tricyclic antidepressant. So please understand. So we have even more drugs, the older ones, older drugs such as desmipramine. Okay, so desmipramine, as you said, there is one more drug, that is amoxapine. So there are so many drugs. Among these, what are important for us? Guys, please remember only these three drugs: imipramine, amitriptyline, nortriptyline. Finished. Rest others not used clinically widely, so they are not so much important. Okay. Now, guys, tricyclic antidepressant. What are the uses of these drugs? Uses are very interesting. So these tricyclic antidepressants are used in the depression treatment. Of course, depression you can use them. That is the sole purpose the drugs were made. But sir. All antidepressant, they were supposed to be used only for depression. No, they're not just used for only for depression, but rather they are way too much having different uses, such as migraine prophylaxis. Wow. Migraine prophylaxis. Migraine prophylaxis, earlier I taught one more drug, that is, anybody can tell me? I taught you people already. There is one more drug which can be used in the prophylaxis of migraine. Very good, propranolol. Very good, propranolol. Even it can be used. Ergots nowadays they are not used. Yeah, earlier we used to use them, but now two major ones. One of them is TCA, another one is propranolol. Okay. Then, guys, we have one more important aspect. What is that next important aspect? They are used for nocturnal anuresis. So babies used to do the bedwetting. That bedwetting problem can be treated with the help of your tricyclic antidepressant. Even imipramine, one drug is useful in overactive bladder. So all these things are uses of the tricyclic antidepressant. Okay. Now, guys, let's go to the next group of drugs. The next group of drugs are your SSRIs. SSRIs are nothing but selective serotonin serotonin reuptake inhibitors, selective serotonin reuptake inhibitor. So basically they're majorly dealing with your serotonin alone. Okay, now these drugs, again my dear students, we have drugs such as, what are the drugs, can anybody tell me? Fluoxetine. What is that? Fluoxetine. What is that? Fluoxetine. Okay, anything else? Very good, that is your paroxetine. Okay, is there anything else? Yes, we have sertraline. What is it? Sertraline. Okay, apart from sertraline, we have citrolapam. We have something called as citrolapam. That is citrolapam. We have one more drug called as acetrolapam. Okay, all these drugs are your selective serotonin reuptake inhibitors. Okay, now selective serotonin reuptake inhibitor uses, where do we use them? We use them in the treatment of depression, of course, depression. Apart from depression, SSRI, selective serotonin reuptake inhibitors, are used in the obsessive compulsive disorder. They can also be used for kleptomania. Okay, they can also be used for kleptomania. Okay, apart from that, where else we can use them? They're used for psychogenic. What is that? Psychogenic premature ejaculation. Yes. So psychogenic premature ejaculation, the drug of choice is your fluoxetine, guys. That is your fluoxetine. It is a drug of choice for your, that is your psychogenic premature ejaculation. So what is the most common cause of premature ejaculation in India? What is that? So the most common cause is psychogenic. We call it as psychogenic. Stress is the cause, but it is affecting psychologically. We call it as a psychogenic premature ejaculation. Okay. Once we are done with that, we are left out with SNRIs. What is that? SNRIs. Okay, SNRIs means, how many of you think a selective norepinephrine reuptake inhibitor? No, that is not the thing here. These SNRIs, they will inhibit serotonin and norepinephrine reuptake. Sir, already you told us, no? Tricyclic antidepressant also does the same action. So here is the very confusing part. Both of them have similar mechanism, but tricyclic antidepressant has similar structure, chemical structure, oldest drugs. So that is why they are classified separately as tricyclic antidepressants, and SNRIs are separately classified. So the drugs are duloxetine. We have a drug called as duloxetine. What is that? Duloxetine. So don't get confused by looking at what is that, fluoxetine and paroxetine. By looking at them, you might get confused. So please remember, that is your duloxetine. We have one more drug called as vanlaflaxine. What is that? Vanlaflaxine. So these are the two drugs, vanlaflaxine and duloxetine, are the two drugs which are again selective serotonin and norepinephrine reuptake inhibitor. Then we have milnacipran. These drugs are not used anymore. They are not at all added into this list. We focus only on two drugs, duloxetine and vanlaflaxine. Don't put your mind into extra pressure by trying to remember these things. Okay, remember only two drugs, that is duloxetine, vanlaflaxine. Clear? So once you understood about SNRIs, we have one last drug. What is that? Last drug, that is called as a special drug base. Bupropion. What is that? Bupropion. What is the use of this bupropion? See, they're used for depression. They're used for the depression. We don't have any specific uses like extra uses like your TCS and TCS and your SSRIs. We don't have any extra such uses. So they're just used for depression. So please understand, this is This is norepinephrine and dopamine. Very good. Dopamine reuptake inhibit the reuptake. Okay, so it is inhibiting the reuptake of norepinephrine and dopamine. Norepinephrine and dopamine. If it is inhibiting the reuptake of norepinephrine and dopamine, my dear students, understand this is one of the very important one. Why this is important? Because these drugs get metabolized. Okay, so in the body it will get metabolized into something amphetamine. It will get metabolized into amphetamine. Amphetamines are substances of abuse, so they can break down, get converted into amphetamine. This bupropion can be used for one of the most important use for smoking cessation. So if at all somebody is smoking, so to get rid of smoking habit, so we use this drug smoking cessation. We use this drug, that is bupropion. That is your bupropion. But when I'm trying to tell you people, it's not just for the smoking cessation, but also called, this is called as atypical antidepressant. It is called as atypical antidepressant. It is called as atypical antidepressant. It is called as atypical antidepressant. This is one of the most important you need to understand. So bupropion is a drug which is an antidepressant, but it will inhibit the reuptake of norepinephrine and dopamine. Inhibit the reuptake of norepinephrine and dopamine, and it is called as a typical antidepressant, and it will get converted into amphetamine. Clear, everybody? Clear? So with this much being said, we are done with the central nervous system. We are done with the central nervous system. Okay, so once we are done with the central nervous system, then shall we start the next topic? See, we have 30 more minutes. In 30 more minutes, shall I start the next topic? CNS is done. Very good, very good, very good. So the next important topic I want to teach you people. See, these are very, very small ones. Okay, this will get over very easy. So what is the next important topic I want to teach you people? Guys, first and foremost important topic I wanted to teach you people is anticoagulants. Anticoagulants. What is this anticoagulants? Okay, now anticoagulants, if you need to understand, you need to know a lot about clotting factors. Tell me honestly, how many of you know the pathway, the clotting cascade mechanism? How many of you know this clotting cascade mechanism? Yeah, please tell me, guys. So very easy, anticoagulants, and one more drug is there, antiplatelets. One more drugs are there, antiplatelets. Okay, now listen to me very carefully. Let's go from the basic physiology. Shall I just run into the topic, or we'll do from the basic physiology, like very basics? So which one shall we do? Basics will do. Okay, now you have a blood vessel. Okay, you have a blood vessel. Now, what happens inside this blood vessel? Please understand. If at all you have blood vessel, if you look inside the blood vessel, you have endothelial layer. If you look at the blood vessel, you will have endothelial layer. Now, below the endothelium, we will have tunica media layer. That is a smooth muscle layer of the blood vessel, tunica media layer. Okay, now please don't call it as it looks like bamboo, sir. No, then we have a last layer called as tunica adventitia, tunica externa. Okay, so tunica intima, tunica media, tunica externa, layers of the blood vessel. Now here what happens? Any given point of time, time, if your endothelium ruptures, or if at all blood vessel itself rupture, basically if there is an injury in the blood vessel, what will happen? The first thing to stop the bleeding, there will be vasoconstriction of the blood vessel. After vasoconstriction, the second process will start, called as platelet aggregation. Followed by the platelet aggregation, then there will be a clot formation. So think about this. Every given point of time, if endothelium damages, that is sufficient, any damage to the blood vessel, there will be vasoconstriction, platelet aggregation, clot formation. All these three processes will occur. So basically your body is thinking that you are bleeding out somewhere and your body is trying to prevent the blood loss. Okay, so by doing a clot formation. Now think about this. What happens is that, guys, during the platelet aggregation, as soon as your endothelium ruptures, it will release something called as thromboxane A2, guys. It will release something called as thromboxane A2. Now this thromboxane A2 will act on the platelet. Now thromboxane A2, once it act on the platelet, it will increase. See, thromboxane A2, what it will do inside the cell, I'll tell you people. Thromboxane A2 will activate an enzyme called as phospholipase. Now this phospholipase will create two substances in anywhere phospholipase. In that also we have a subtype called phospholipase C. Once phospholipase C activates, it will create two substances called as IP3 and DAG. Okay. Now what happened? IP3 and DAG are formed. So this IP3 is inside the cell. Okay, and there is one more substance, DAG is inside. Now this IP3 and DAG will go and stimulate platelet granules. Okay, now once platelet granules, so what happened? Because of this, they will stimulate the platelet granules. So once platelet granules will be stimulated, that will lead to whatever is present inside that granule. It will release substances. Such as ADP. So basically simple rule. We have a platelet. Inside the platelet, some granules are there. That granule contain many substances. Rule number 1. So that granule will become that breakdown will occur only when there is IP3 and DAG will come. Okay. Now what happens is that this ADP and along with that it will also release substances such as thrombin. Apart from that, it will also activate other receptors. What exactly is that? This ADP will activate some receptor called as a P2 white valve receptor. Now what happens? The granule released P2 white ADP stimulates somebody called as P2 white valve. Okay. Now because of this P2 white valve activation, there will be platelet aggregation. So what I'm trying to tell you people is that one process which is P2 white valve activation led to the aggregation that happened with the help of ADP. Now, again, this thrombin will stimulate receptors called as PAR receptors. So it will activate PAR receptor. Again, that will also lead to to aggregation. That will also lead to aggregation. So platelet aggregation has to occur, means your blood vessel was ruptured. Here all the platelet will come and aggregate in one place. So for this aggregation to occur, all these processes are required, such as P2Y12 receptor, such as PAR receptor, even other proteins also required for the aggregation, such as glycoprotein such as 2B3A, glycoprotein 2B3A. Okay, so many proteins made all platelets to come together. Okay, now sir, it is good thing only. Now why are we learning about it? We are learning about it because, for example, imagine atherosclerosis. We have, what is the disorder? Atherosclerosis. Atherosclerosis, what happens is that, look here, we have this layer. Now we have this one more inner layer called as endothelial layer. Okay, now when you look under this endothelial layer in this particular disorder, which disorder? Atherosclerosis, what happens is like this. A disorder will become like this. So what is that? Below this endothelial layer, what happens? Fat will get accumulated. Okay, now fat will get accumulated at one time. What can happen is that it will rupture the blood vessel. Exactly which one? Endothelial layer. So what happens once endothelial layer is ruptured? Immediately platelets will become aggregated. Now this aggregated platelet, later it will become a clot. If it become a clot, what happens to the blood supply? Blood supply will be decreased or increased. Now see, this blood vessel was, for example, coronary artery. So that plaque ruptured. After plaque rupture, clot has been formed like this, big one. Okay, if clot has been formed, blood supply will be there or it will be stopped? Blood supply will be there or it will be stopped. Automatically, blood supply will be stopped. If blood supply is stopped, means clot. See, this atherosclerotic plaque rupture can lead to clot formation. That clot formation can lead to cut down of the blood supply. If cut down of the blood supply is there, then person can end up having myocardial infarction. So this becomes a very dangerous issue for us. So what exactly we need to? Atherosclerosis. We need to use which type of drugs? Prevent the clot. To prevent the clot, we use antiplatelets. So antiplatelets are the drugs. Antiplatelets are the drugs which we use them for the treatment. So antiplatelet drugs, we have something called as P2Y12 blockers. What is this P2Y12 blocker, my dear? P2Y12 blockers, we have drugs such as clopidogrel. Apart from clopidogrel, we have one more drug called as ticlopidine. Pidine, not dipine. Okay, ticlopidine. What is the name of the drug? Ticlopidine. Okay, ticlopidine. And we have one more drug called as prasugrel. What is that? Prasugrel. Clopidogrel, prasugrel. Okay, now we have even few more. We have such as canagrelor. Okay, then we have one more drug called as tigagrelor. Sir, why did you write them separately? Because these P2Y12 blockers, they are irreversible blockers. These are your reversible blockers. Okay, now sir, should we remember all these names? Sir, already we are getting irritated. So annoying names, we feel like vomiting by looking at the names. If you can't remember everything, I request you to remember this much. Clopidogrel is what? Antiplatelet. Okay, this is one group of drugs. Okay, then there is one more group of drugs. So what is that one more group of drugs? That is your GP, glycoprotein was there, na? 2B3A blocker. Ah, yes, sir. 2B3A blocker was there. Yes. So 2B3A was helping aggregation. I can block it. Okay. So we have drugs that is called as apixaban. Apixaban. So I told you people, MAB means that is monoclonal antibody. MAB means what is that? Monoclonal antibody. MAB means monoclonal antibody. Okay. Then we have one more drug called as tirofiban. Okay. I'm putting these drugs at the end because I'm pretty sure in that you people will end up remembering this much. Okay. Clear? Now. We had some other receptor. Just remember the names. All of them have only one use. That is to prevent the clot formation. Okay. Now, tirofiban. Now, once you understood about this, my dear students, we have one more drug that is your COX inhibitor. That is your aspirin. Okay. If COX is inhibited, no thromboxane A2. If no thromboxane A2, no clot formation. So that is why we can use aspirin. Guys, just give me 1 second. There is some disturbance coming up. Okay, I'm sorry guys, there was some disturbance, just I wanted to clear it. Okay, yeah. No, just there was some disturbance, that's why I muted and I sorted it, that's it. Okay, I'm back. So we have thromboxane A2, that is no thromboxane A2 means no clot formation. These are the most important widely used antiplatelet drugs which you need to remember. Then we have other drugs, that is PAR. What is that? PAR antagonist. So guys, PAR antagonist. PAR full form is nothing but protease activated receptors. So this protease activated receptor is nothing but your PAR. PAR used to be activated by your thrombin. Now, my dear students, these PAR antagonists, we have drugs such as Oroxapar. What is that? We have what is that? Oroxapar. We have one more drug called as Etoxapar. What is that? Etoxapar. Clear, everybody? Clear? So among these, if you remember two drugs, aspirin and clopidogrel, your life is set. Nothing to worry. Okay. Then I want you to understand the next important. First one, what we did, we prevented the clot formation. So first stage done. Platelet. See, vasoconstriction is not a significant thing. Okay. Platelet aggregation done. We targeted. Then clot formation. So clot formation will be targeted by next group of drugs which we are going to discuss. They're called as anticoagulants. They're your anticoagulants. Okay. So anticoagulants. First thing, anticoagulants, my dear students, what exactly these anticoagulants? Listen to me very carefully. These anticoagulants prevent clot formation. Clot formation. If they're preventing the clot formation, where and all we can use users. Of course, clots are formed in the blood vessel leading to stroke. Okay, so we can use them in the stroke patient. Okay, the clots are formed in the blood vessels of the heart, leading to what is that? That is myocardial infarction. Okay, where else we can use them? Deep vein thrombosis is also a clot. DVT is also a clot. Apart from DVT, where else we can use? Guys, we can use in atrial fibrillation. Sir, atrial fibrillation, what it has to do with the clot? Now listen to me very carefully. In atrial fibrillation, atria gets dilated. Once atria gets dilated, there will be clot formation in the atria itself. That is very dangerous condition. So for that person also, we need to give what is that? Anticoagulants. We need to give what is that? Anticoagulants. Okay. Now, after understanding this uses, so where we are going to use one simple rule, any hypercoagulable state, we are going to use it in a hypercoagulable states. Any hypercoagulable state, we are going to use this drug. That is only your anticoagulants. Okay. So for that anticoagulants to be understood, my dear students, we need to understand one of the most important thing, that is your clotting cascade. What is that? Clotting cascade. What is that? Clotting cascade. Okay. Now clotting cascade, if we need to understand, they're very easy. Okay. That clotting cascade have three pathways. One of them is called as an intrinsic pathway. Okay. Then another one, we call it as a extrinsic pathway. What is that? Extrinsic pathway. Okay, so what is the intrinsic pathway? What is extrinsic pathway? Listen to me very carefully. Guys, it's very easy to understand. You have a blood vessel. You have a blood vessel like this. Okay, now you have a blood vessel. Now, in the blood vessel, what do you have is your blood. Okay, so depending upon, see, this clotting has to occur, means clotting factors are needed. So where does clotting factor come from? If at all some clotting factor comes from your blood vessel, some clotting factor is coming from where? From the blood vessel, means it is coming from the tissue. Then we call that pathway as a extrinsic pathway. So clotting occurs, but with the help of the factors which are coming from the tissue, we call it as an extrinsic pathway. If at all blood itself contains some clotting factor which made the clots formation possible, then we call it as an intrinsic pathway. Okay, so intrinsic means the factors are present inside the blood itself. Extrinsic means factors are coming from outside of the body. Not outside of the body, outside of the blood. Okay, now when you're looking at an intrinsic pathway, the first factor which will get activated, that will be your factor number 12 will become into 12A. A is nothing but activated factor. What is that? Activated factor. Okay. Now I'll give you the names and I'll give a technique to remember it also. Don't worry. Now, these 12th factor became activated. Now, with the help of this 12th factor, what is going to happen is that my 11th factor will become active. Basically, the activated 12th factor is helping the activation of 11th factor, Okay. Now, this activated 11th factor will go and activate factor number 9. So, not 10, rather it will activate factor number 9, my dear students. So, what is that? 9. Okay. Now, listen to me very carefully. Factor number 9, with the help of that is your factor 8, with the help of factor 8 and calcium, will activate the 10th factor, Okay. Now, what about extrinsic pathway, sir? That extrinsic pathway is that this factor number 7, with the help of factor number 3, it will activate your factor 10 into 10A, So what is the summary of your both pathways, intrinsic pathway, be it extrinsic pathway, both of them will activate one common pathway, that is only your 10th factor. Now, this 10th factor, with the help of your 5th factor, will activate factor number 2 into 2A. So when you're talking about 2 into 2A is nothing but factor 2 name is only called as prothrombin. Prothrombin will become activated into thrombin. Okay. Now this activated thrombin will convert factor 1 to 1A. Factor 1 to 1A. That factor 1A is nothing but the first factor that is important one, that is fibrinogen. Fibrinogen will get converted into fibrin. Now this fibrin will make the clot, and this clot has to form, means whatever fibrin got activated, it should become stabilized. This stabilization will happen with the help of fibrin stabilizing factor. So my dear students, whenever I ask you people, you need to understand one thing here. So common pathway is after factor number 10. Common pathway is after factor number. Till here it is your intrinsic pathway. Till here it is extrinsic pathway. Extrinsic pathway is easy to remember. Factor number 3 and factor number 7. Both of them 3 plus 7 is equal to 10. Basically they activated 10th. Now sir, how do we remember this one, especially with the names of this factor? It is very easy. How to remember? Mnemonic technique. The technique to remember intrinsic pathway, exactly in their order, you just go with this one. HPC, antivirus. What is that? Antivirus cost $10. Okay, so this HPC is something which I made it up. Okay, so H for Hagman factor. So that Hagman factor is your factor number 12. Factor number 11, that is only called as plasma thromboplastin. Okay, that is only your factor number. This one was 12, this one was 12, then this one was your 11. Factor number 9 is called as a Christmas factor. So this Christmas factor is your factor number 9. So anti means anti-hemophilic factor. I'll tell you which ones to remember also. Don't worry. You don't have to worry. I'm giving you content, but at the end, I'll give you which ones to remember. Just give me a few seconds. Okay. Now, anti for anti-hemophilic factor. Cost means C for calcium. 10 for 10th factor. Okay, so if you look here, calcium itself is your 4th factor, anti-hemophilic factor is your 8th factor. Okay, so when you look here, if you remember this order, you can use this mnemonic, that is your intrinsic pathway mnemonic, intrinsic pathway. Okay, among these, if you don't want to remember anything, take a breath, chill, and remember anti-hemophilic factor is factor 8. And factor 9 is Christmas factor, because their deficiencies causes a disease called as hemophilia. Their deficiency causes a disease called as hemophilia. Okay, guys, in the human body itself, so there are some stages where clots can occur unnecessarily. Okay, so our body also has to prevent the clots from formation. How exactly these work? They work? So we need to know the natural anticoagulants. But just remember these two factors. Rest everything. Just if you can remember, else no need. Earlier times, some like 2007, 2008 were the times where they used to ask what is the name of factor 3, what is the name of factor 4, and all. Now they don't ask those kind of questions anymore, so you don't have to worry. All right. Okay. So we need to understand something called as natural anticoagulants. Natural anticoagulants. anticoagulants. Sir, what are natural anticoagulants? Natural anticoagulants are the coagulants which are the substances which are present in the human body which prevent the clot formation. Those natural anticoagulants are called as, my dear students, they are your proteins. They are called as protein C and protein S, and we have one more substance called as antithrombin 3. Antithrombin 3. So these are the most important natural anticoagulants which are present in the human body to do the anticoagulant action. Okay. Now the drugs we use contains something called as indirect anticoagulants. So indirect anticoagulants, one of the classic ones you have, my dear students, that's your heparin. What is that? Heparin. Sir, what is this heparin? Heparin contains, so we have something called as heparin called as unfractionated heparin. We call it as a unfractionated heparin. I'll tell you people, unfractionated heparin means the size of the heparin is very large. The size of the molecule is large and it cannot be taken orally. It cannot be given subcutaneously. Most of the times we had to use it IV only. So this unfractionated heparin can be used only IV. So if it was only IV, we could not use. So for that purpose, what we did, we developed better drugs. The better ones, better ones we developed, the better are LMWH. What is that? LMWH. What is this LMWH? That is only called as low molecular weight heparin. What is that? Low molecular weight heparin. So this low molecular weight heparin, which can be given subcutaneously, and you don't have to do any lab monitoring is not required. Lab monitoring is not needed. So that is a major advantage. Not needed. So if it is not needed, we can use widely in a patient. So that was the advantage of using this. That is low molecular weight heparin. So low molecular weight heparins, we have drugs such as enoxaparin, okay, and we have one more drug that is called as daltoparinix. Okay, these are the two low molecular weight heparins which are present. Okay, now understand these two drugs are there, but we have one more drug that is fondoparinix. What is that? Fondoparinix. What is this fondoparinix? My dear students, fondoparinix is also a type of heparin, but you people think it is a low molecular heparin, but it is not a low molecular heparin. It is not a low molecular weight heparin, which you need to remember. Okay. So once I teach you people about this mechanism of action of heparin, a mechanism of action is very easy. Heparin has two different mechanisms. Heparin bind with the antithrombin 3. Okay. So if it is binding with the antithrombin 3 and increase the action of the antithrombin 3, simple as that. So antithrombin works as an anticoagulant, but when my heparin goes and binds, be it low molecular weight, be it high molecular weight, any heparin goes and binds with this antithrombin 3, that antithrombin 3 activity increase by 100 times. So increase action of antithrombin 3. So that is one mechanism. And my dear students, this heparin will also inhibit factors. That factor C, if at all I stop the factor, fibrin will not form, clot will not form. So it will inhibit the factor number 2 and 10. So this is the direct mechanism of the heparin, and indirect mechanism of the heparin is this one, antithrombin mechanism. Okay. So guys, Now we have some side effects of heparin. We have some side effects of heparin. Side effects of heparin is very interesting because heparin will cause something called as osteoporosis. What is that? Osteoporosis. Heparin will cause which side effect? Osteoporosis. Apart from heparin causing osteoporosis, it will also cause heparin induces thrombocytopenia. And what is this? Induces thrombocytopenia means what? This very simple means, guys, heparin, when you give it again and again, repeatedly, heparin will trigger the destruction of the platelet. Heparin will trigger the destruction of the platelet, leading to decreased platelet count. So induces thrombocytopenia. Okay. So they can ask you anticoagulant with the antiplatelet effect. That anticoagulant with the antiplatelet effect is caused by your heparin. This is a very important question which can be asked to you people, which can be very much important because it was asked in recent times like numerously. So please be ready with it. They can ask the question from here. Okay. Now I told you about this much. But my dear students, listen to me very carefully. Heparin is safe in pregnancy, but the major problem is that there is a osteoporosis. Okay, so we need to keep in mind with the osteoporosis when we are using in a pregnant female. Okay, now we have some drugs, direct thrombin inhibitors. So directly, see, factor 2 was prothrombin. Prothrombin was getting converted into thrombin. Now, if I go and inhibit that thrombin, automatically fibrinogen will not get converted into fibrin. So there is no clot formation. So that's how they're working. They have drugs such as lipuridine. We have drugs such as bivalerudine. We have drugs such as lipuridine, bivalerudine, and we have one more drug such as that is called as hirudin. Okay, so these are directly used. Okay, but there was one problem. There is one problem. That problem is these cannot be taken orally. If cannot be taken orally, you cannot inject this drug daily to the patient. We cannot inject drug daily. So there is one more drug that is called as, my dear students, dabigatran. What is that? Dabigatran. Okay, this dabigatran orally available in the form of tablets. So we can use this drug. Dabigatran. Okay. Now dabigatran. Then there is one more drug that is rivaroxaban. Okay, but rivaroxaban is a drug which inhibits somebody else. Why I put these two things here? Because see, dabigatran is like rivaroxaban mechanism is a 10A inhibitor. It is a 10A inhibitor. But these two drugs comes under novel oral anticoagulants. So what is this? Listen to me very carefully. Rivaroxaban, please don't get confused. It's a 10A inhibitor. We are going to the next step there only. That is a factor 10A inhibitor. Factor 10A inhibitor. Look here. Activated factor number 10 was present in the common pathway. So if common pathway itself is inhibited, you can prevent factor 10A inhibitor. The factor 10A inhibitor, they're very easily you can remember, that is called as apixaban. What is that? Apixaban. Okay, we have drug called as edoxaban. What is that? Edoxaban. Okay, rivaroxaban. Okay, Rivaroxaban. Okay, so all these drugs, if you focus and look here, they're basically inhibiting factor number 10. They're banning factor number 10. So they will, the name itself will contain, you can remember these drugs can be orally taken. These drugs can be orally taken. So they will become novel oral anticoagulants. They come under novel oral anticoagulants. One of them is dabigatran and factor 10A inhibitor. So this is the story of your anticoagulants, but we are left out with one interesting drug, that is your warfarin. Okay. Now look here, guys. Warfarin is such a drug. Very interesting drug. That is. So warfarin is easy to remember. Okay, warfarin is a coumadin derivative. It is a coumadin derivative. Now this coumadin derivative, whatever is there, this coumadin derivative, earlier time we had a chemical called as neodecumerol, okay, even before warfarin. But it has so many problems, we banned it. We use only warfarin. Now when I'm talking about warfarin, what is the mechanism of action of warfarin? Okay, the mechanism of action of warfarin is easy to understand. So you have something called as precursor stage. Precursor stage means what? Unformed, ungenerated, inactive. So these type of stage. So it is a raw material stage. We call it as a precursor stage. Precursor 2, 7, 9, 10 factors 2, 7, 9, 10 will undergo a process called as gamma carboxylation to form 2, 7, 9, 10 to form the 2, 7, 9, 10. Okay, now if at all they have to form, that requires vitamin K epoxide. It requires vitamin K epoxide. Now this vitamin K epoxide undergoes reduction, will create gamma carboxylation to happen. So if gamma carboxylation has to occur, vitamin K is needed. Only then you'll get a 2, 7, 9, 10. If not, you are not getting 2, 7, 9, 10. Now this vitamin K after reduction, we call it as a vitamin K reduced form. Okay, now this vitamin K reduced form is there. This reduced vitamin K, now what will happen? Again, it will become epoxide form with the help of an enzyme called as vitamin K epoxidase. Okay, epoxidase is an enzyme. Vitamin K epoxidase is an enzyme which will convert reduced vitamin K into epoxide form, so that again we can form factor number 2, 7, 9, 10. Factor number 2, 7, 9, 10. So factor number 2, 7, 9, 10 has to 9, 9, 10 has to form, means you require vitamin K epoxide. Now what exactly warfarin does? Warfarin will inhibit this enzyme. So this enzyme inhibition is only mechanism of action of warfarin. So automatically warfarin decrease the synthesis of factor number 2, 7, 9, 10. 2, 7, 9, 10. Now, when you look at a warfarin, my dear students, always remember warfarin slow onset of action. Slow onset of action means it will, today you give warfarin, it won't work today only. It will take at least 3 to 5 days to show the action. Okay, so it will take at least 3 to 5 days to show the mechanism of action. It is a slow onset. So that is why whenever warfarin, at the start of the warfarin, we do something called as heparin and warfarin bridging. What is that? Heparin and warfarin bridging. So what is this heparin and warfarin bridging? Now listen to me. For how many days? For 5 days. For 5 days. Sir, what exactly you're doing? Very easy, sir. It's so easy. Day 0. Okay. Day 1, day 2, day 3, day 4, day 5. For example, I gave warfarin today. Now, warfarin which I gave today will show the action on 3rd day. Second day, I will give warfarin. Now, it will show the action on, for example, when? So, first, second, third day. Okay. It will show the action on 4th day. Now, warfarin which I gave 3rd day, it will show the action on 5th day. Okay. But so the effect you are getting it from at least after 3 days. But in the first 2 days, you need an anticoagulant property. So that can be covered with heparin. So that only, but sometimes some people action might occur on 3 days, some people 4 days, some people 5 days. So we don't know. For 5 days, just combine warfarin and heparin together. After that, after 5th day, from here warfarin only. From here, warfarin only. This is the story of your using of warfarin as a heparin warfarin bridging, Okay. Now, guys, it is contraindicated. In first trimester. It is contraindicated in the first trimester because it causes fetal warfarin syndrome. So any female, if she develops DVT during the pregnancy, you cannot give her warfarin in the first trimester. You can consider giving warfarin in the second trimester. For example, in pregnancy, if you want to use first trimester, which you are going to use is heparin. But the problem is that heparin will cause osteoporosis, and pregnant female requires a strong active bones. Now, what we are going to do after the first trimester? So after the first trimester, now baby organogenesis is complete. If baby's organogenesis is complete, now you can give drugs. Such as warfarin, because now no problem. Okay. Now again, what you are going to do? Just keep it in RN warfarin only, but few days before delivery. What is that? Few days before delivery, then you can shift her to the heparin, and after that, based on the surgical concern and requirement, you can decide whether to give heparin, not to give. Even if you stop immediately, the effect can be achieved. That is one. Okay. Now, last thing which I wanted to tell you is that when you give warfarin, if warfarin is given, we need to monitor. But not therapeutic drug. If warfarin given, we need to monitor something called as INR. What is that? INR. It is not Indian rupee. It is international normalized ratio. Okay. It shows the blood clotting stage of a person. Okay. So that INR should be monitored in a patient with warfarin. But warfarin, does it require therapeutic drug monitoring? No. Warfarin does not require therapeutic drug monitoring. Rather, it requires INR monitoring. Clear? So it should be maintained less than 1.5, but sometimes what we do is 1.7 to 2, like 1.7 to 1.8, that we can allow, but more than that, it is dangerous. Okay. So that you learn from the medicine aspect, because in pharma itself, we have already discussed so much. All right, guys, with this much being said, we will conclude the class here for today. See you people tomorrow. All right. Enjoyed the class today? अच्छा, लोग गया भी हो गए. अच्छा, लंबा क्लास था. It was long class, so we are saturated. You people left on there. All right, guys. Bye bye. See you people. Thank you. Bye bye.